And at the end of it, we hope you learn something which will help in your practice. This wouldn't have been possible without support of three important people. Dr. S.V. Kulkarni sir, he's the chairperson of API, he's a senior consultant, physician, and digital media technology expert. And if I have to speak about him, I think I can do an entire CME on that. So we are blessed, sir, with your presence today. Dr. Ghansham Dulera sir, President, IMA Navi Mumbai. He's been the most supportive guy whenever we plan our CMEs and always very clear in giving feedback what was good and what could have been done better. And a special thanks to Dr. Alka Patnaik Madam, Secretary IMA Navi Mumbai. She was very pro. I think first call and within 2 minutes we got a green signal that this looks to be a good program to go ahead immediately. Obviously, I cannot proceed without a disclaimer. A lot of products, images will be portrayed. I am not promoting them. You are free to use a brand of your choice. This is just for purely discussion purpose. So I would request Dr. Nitin Jagasia. He is the Regional Head, Emergency Medical Services, Western Region, Apollo Hospitals, to deliver a welcome note to all of you.
So good morning, everyone. I'll just echo what Akshay has just said, that it's great to see all of you here. For those who are like me, very time conscious, the whole point of my name and welcome note of 20 minutes, kuch nahi hai. It's a buffer so that we don't delay. So we'll be running on time. So it's great to see all of you here. And you all have all seen the program. So rather than me saying anything, I would just like to know what you all are looking forward to from today. You can just shout out. What do you think you want to get from today?
Basic management of all emergencies at the GP level in their clinic or home.
Okay, great. We planned for that. What else? Yes, sir.
Urgent referrals can be arranged to a tertiary care center.
Excellent. We planned for that. Good. Anything else? Latest in the field of different specialities, yeah. So thank you. That is basically what I had to say. So what we have planned today is not a death by PowerPoint at all. It is only a question answer session. We have created some questions for our experts, cardiologists, neurologists, trauma and orthopedics, infectious diseases. That is today's session. We'll be having a second session in the end of March where we can take the other specialities. So today is just part one, and during that, we just asked the experts exactly what you all have highlighted. That what is the time critical nature, which are the ones we need to filter out, because you are seeing so many patients every day. Not everybody needs a time critical intervention. So our entire focus is on that, and we'll stick to that. Of course, we will want to have it interactive as well during the session as much as time allows. We've got a timer. Like I said, I'm a little bit stuck on time. And rest of the questions can carry on during the tea break or maybe the lunch break, and plus we will be sharing all the important numbers that you can get back to us on. So that's all I wanted to say. So welcome everyone, and thanks for really being here, because Navi Mumbai, we have a unique opportunity. We are actually a developed Mumbai, right? It is much more structured, much more organized. And with the work that IMA Navi Mumbai is also doing, we are creating the same structure within our medical community. So this is just the same thing that we are all in it together. Thank you.
So let's begin with discussing on animal bites, where we are going to touch base more on the rabies management. So I'll invite our champion and the panelist. To start with, I'll invite Dr. Dhanya Dharmapalan. She's a consultant pediatrics and pediatric infectious disease at Apollo Hospitals. She'll be our champion to take care of all the gray zones. Then I would request our panelist, Dr. Sameer Sahasrabuddhe. He needs no introduction. Consultant physician and critical care, Sahasrabuddhe Hospital and ICCU at Panvel. The photo is of his older self. He looks more younger right now. Sir, can I please request you to be on the stage? I found a very interesting line which I didn't understand when he put it on Twitter. that he was eagerly waiting for the monsoon season to start in full flow. I think after 10 years, I understand why. And I would like to invite Dr. Girish Muharir sir. He's a consultant general and laparoscopic surgeon at Sri Hospital Vashi, as well as Apollo Hospitals, Belapur. So with our experts assembled, I think let's start off with the basics. So I would start with Samir sir. You have a patient with animal bite. What is the first thing you want to do after animal bite, other than running away and beating the animal?
If I get the patient in my hospital, first will be to reassure the patient that don't worry. Then get to know what type of animal bite it is, whether it's a rodent, whether it is a mammal, whether it is something else. Then looking at the wound, degree of injury, like how severe is the injury accordingly. And if it is a animal bite, which is say cat, dog or something, then you have to think of anti-rabies immunoglobulins as well as anti-rabies vaccination. If it is something else, if it is a snake bite or something like that, then accordingly whether you can make it out whether it's a poisonous snake or a non-poisonous snake, well. If it is not easy to make it out, then you have to follow the guidelines which they say, like you can do a short blood clotting test. You can do a short blood clot test, which will be a bedside test. Then light tourniquet can be applied, which can just prevent the lymphatic drainage, not the arterial or venous drainage. And then proceed accordingly, cleaning of the wound, dressing if it is not a mammal bite which is not to be dressed. If it is a severe bite, suturing can still be done, but with a lot of precautions which you have to take.
So there's been always a debate about cleaning the wound. What would you recommend when such patients
Plain
come?
water.
Okay,
Plain water.
okay. So I would request Dr. Girish to answer the next one. The wound is bleeding. How do I stop the bleeding immediately? Simplest way.
Pressure is the simplest way always. And if there is any specific bleeder, then you need to tackle it accordingly. But general ooze can easily be controlled with pressure.
Do you recommend applying tourniquet? Say this is a animal bite, and
Sorry?
do you recommend applying tourniquet?
Tourniquet, not usually.
So it's just direct pressure.
Direct pressure is always better.
And roughly for how many minutes you would recommend this to be done?
See, the pressure you should apply actually between 5 to 7 minutes for a proper hemostasis of a general ooze. And if there is a specific bleeder, then it is better to tackle it by ligation individually, rather than just keeping pressure on.
Okay, okay. So my next question to the champion, obviously, we have done our basic management. We have taken care of identifying the animal, it's an animal bite. We have taken care of the bleeding, say the wound is washed. Now, what is your next decision making for post-exposure prophylaxis? How do we decide?
Hello?
Yeah.
So, what's very important when there's a stray dog bite is first thing that is to be done is ask the patient or the caretaker to wash the wound for good 15 minutes with soap and water. The reason is this is as critical as giving post-exposure prophylaxis with vaccines or immunoglobulin. And the reason is that rabies virus is lipophilic. It is destroyed by soap. So that maximum care is taken in the first 15 minutes itself. It should be running water. So what happens is when a patient is referred to a tertiary center, this critical first aid simplest measure is sometimes missed. So please ensure that. Then you need to, you all are all aware of the WHO category of the wound, that is type 1, type 2, type 3. And type 1 is just licking while feeding. It is bite on an uncovered skin and you don't see any mark. But sometimes it becomes tricky to differentiate it between type 2, where there is a single abrasion without bleed. Some experts talk about using a spirit test, where you can apply spirit and check for burning at that site. That means it is type 2. And type 3 is any wound where even a single drop of blood you see, you categorize as type 3. Now the difference is that for the first one, just washing is enough. But for the type 2, you need to give rabies vaccines. Now as per our NCDC guideline, it is 5-dose rabies vaccine, so 0, 3, 7, 14 and 28. But recently WHO has reduced that 5th dose into 4th dose anytime between 14 to 28 days. But at the same time, since our country has still not adopted that, it is better to advise 5-dose vaccine. The third, category 3 bite, that's extremely crucial that we need to, today's theme is time, and it is essential that the victim gets protected as soon as possible. And because the vaccine will take at least 7 days to generate an immune response, you need to infiltrate locally with an immunoglobulin or a monoclonal antibody over the wound locally. The previous concept that the remaining part can be injected into a distant thigh has been given up. So that is the latest thing, maximum infiltration on the local wound. And of course, the first dose of rabies vaccine goes on the other side of the body. I think I have.
So intradermal or intramuscular?
Yeah, so intradermal.
We have been missing intradermal injections for long now.
Right. Now, the government program has intradermal. Now, intradermal and intramuscular both have been found to have equal efficacy. So, if you get, intradermal is like 2 site injections of 0.1 ml. So, it's not like, if a patient has taken intradermal, then it's not so much protective. The only host where this might be a problem could be an immune compromised host, where intramuscular is better. The second thing is, there is also a recommendation that now you can switch the brands. Of the vaccine, someone has taken somewhere else. Someone has taken in government but wants to now follow in private. So that intradermal to intramuscular switch is also now allowed.
Nowadays there are 2 types of vaccine, like chicken embryo and
Correct, exactly. So,
which one is better?
right, so purified chick embryo and purified viro rab both are equally effective. There is no one above the other. And if a person has taken 1 shot of chick embryo, can change to viro rab if in that institute chick embryo is not available. Though we generally encourage same brand, but you can interchange if the other product is not available.
And is TD also recommended with the Revivex?
Yeah. So now coming to the other aspect, it's going to be covered. What else other than, or should I cover right now?
I think we'll go step by step. We'll take care of that.
When you are talking about local wound infiltration, what does it mean that we inject over the wound or in the wound? Like
In the wound.
So it has to be around the edges towards the wound. The point of the needle should be towards the base of the wound. So I think we'll discuss further about
as
this.
we are going ahead, we'll discuss that. We have challenges for it. Yes, sir. We have that. We have the questions. Don't worry. I have covered those doubts. So a quick rapid fire to Samir sir and Danya madam. Which is better, immunoglobulin, Rabi Shield or Twin Rab? Availability, efficacy. What would you choose? Okay. I was hoping someone will disagree. Good, we started with that.
Yeah. Monoclonal
Monoclonal
antibody
antibody.
is relatively cheaper, easily available.
Single or twin? Now that we have two monoclonal antibody combination also available, what is your choice? Single or twin?
Single one. Yeah.
Ma'am, single, twin?
You said rapid, so I have to be quick, but actually both are licensed, both are safe, both are effective. Twin Rab, I'm not promoting the company, but if you see, you can see that Docaravimab and Mirovimab, it is a cocktail of two murine antibodies, and the reason why you have two antibodies is they can bind to two sides of the rabies virus antigen, so giving a broader protection. So why the broad? Actually, if you go to see, Rabies Shield is very good in our geographical region. But what they have found is there are certain varieties like some bats in the Americas where they have different type of rabies virus which Rabies Shield will not protect. So Rabies Shield is not used in Americas definitely. But here it is sort of, you can give Rabies Shield. It was introduced in 2017, found to be safe in children. Twin Rab is also found to be safe, though it has no specific pediatric trial, but the trials included children and has found to be safe. So for broader coverage, definitely Twin Rab. Now, just one theoretical, if you allow me. Usually you require only lifetime once.
Yeah.
With immunoglobulin or monoclonal antibodies. But there's an exception of immune compromised who would require, because they wouldn't generate that secondary response in future, they may require the PEP again. So there is a theoretical risk proposed by some experts that because this is murine, there can be a possibility of autoantibodies generated towards that, which is not there in Rabies Shield because it is human, which is like human antibodies. So giving second time Twin Rab is sort of discouraged. In that situation, it will be Rabies Shield. So that's the only thing, but that's a theoretical risk.
So coming to the next challenge, which again, sorry, I'm going back to you only, ma'am. So I've been bitten 100 days back. I took entire PEP, category 3. I took active, passive immunization both. Now I have a dog bite again. It's 100 days. Should I take the entire thing? Should I take nothing or what?
So now there's a clear guidance, and you know our children especially are so vulnerable to repeated some scratch or a bite. So the guideline says a cutoff of 3 months. So before, now if you have you need to first check the document, okay? If that's the first thing, that definitely is there complete documentation. If there is a documentation and the bite has happened before 3 months, then you just need to wash the wound. You do not have to even give vaccine. But after 3 months, you need to give the vaccine, and that is 0 and 3 days. That is the 2 doses that you need to give. Are we covering pre-exposure?
Yeah. Oh yeah, we are covering. So that answers the next question also. So if the bite is again within 30 days, we don't do anything. Just wash it and keep it. My next question to Sameer sir. My dog is vaccinated as per age. Do I still need to take PEP? The dog has a complete documentation and
Yes,
everything.
I feel you should still go ahead and vaccinate.
I think older times you used to skip it, but of
No.
late the cold chain maintenance
lot
has
of
been a
things
challenge.
are in between, like rabies is non-treatable as of now almost.
Correct.
So you cannot take chance. There are a
Correct.
lot of drops which you can see the dog may not be vaccinated with a vaccine which is
Correct.
potent, and
So
so many other things.
Okay. So we'll go ahead even if the dog is vaccinated, pet and all in all. Girish sir is feeling missed out, so my next question is to him.
Why only cat 3 bite, not in cat 2 bite?
No, cat 3 is which you're worried most, na?
Second also we are worried.
Yeah, but you have already been immunized before. You're more worried for cat 3 than cat 2.
Not about that vaccinated before. If the dog is vaccinated and it is a cat 2 bite, then
So even we'll continue with everything. Yeah.
are we covering the dose of infiltration?
We'll cover at the end of it. So, Girish sir, how do you decide if the wound needs to get approximated immediately or delayed? You have two cases, one here, second on the other side.
Actually, in neither of the things you will go for immediate suturing of the wound. You will complete at least 3 doses of the vaccination, and if after that you feel the patient needs a secondary suturing, then you will go ahead with it. Otherwise, ideally, it has to be kept open after the wash, infiltration of the immunoglobulin and your post-exposure prophylaxis.
And let's assume hypothetically and in real we also experience it, the bleeding is just not stopping in spite of maximum pressure being applied or anything else given. Do you still take
under anesthesia if you require,
okay,
and tackle the individual bleeder,
okay,
need not close the wound.
And in those cases, does the timing make a difference? When do you land up giving your passive immunization like rabies shield or twin trap or immunoglobulin as closer to the procedure,
Earlier
or
the better.
okay?
Earlier is always
So as early as possible, I should infiltrate and then take it up accordingly.
for
Fine.
hemostasis.
Yep. So one more question for you. Sometimes it's very minor bite and there's always a challenge, not challenge actually if you see the photo. Antibiotics are easily being taken over the counter without much of a challenge. But does an animal bite really require antibiotic?
Ideally, yes, because after all, it is a saliva which is teeming with bacteria, and a lot of it are also anaerobes. So, though the routinely prescribed antibiotic would be amoxicillin clavulanic acid combination, which is advised, I would always add something which covers the anaerobes, like either a metronidazole or ornidazole, and cover for 3 to 5 days. Once the infection is not there, if you're sure about it, then you can stop.
Then you can stop. That fairly makes the right thing to do. My next question is to Samir sir. I missed my dose on day 7 by 2 days. So I came to you on day 9. Can I continue or restart the entire vaccine schedule? What would you recommend?
If it is 2 days, you can still continue the vaccination.
Okay, okay. So I think we'll continue and not restart it. Doses, if you want to touch base, if you're giving immunoglobulins or if you're giving twin trap, what would be the ideal dose that we would recommend body weight wise? How much you want to give?
Yes,
I think immunoglobulin, although it's not given nowadays, 20 international units is what we thought of to start with, the human one. Equine was 40 per kg. But again, like ma'am said, it's drastically changed that you don't land up giving the remaining dose intramuscular. That saves quite a bit.
Unless it's a small part, like
Correct.
you cannot infiltrate around the finger or something, then you may go
Correct.
ahead with the thigh
Correct.
injection. Otherwise, maximum possible you should infiltrate. Or in arteries, if you are worried about,
Correct.
then might be you can give
Correct.
half the dose or
For the
remaining dose.
Wanted to add that.
twin wrap, what would you
So
recommend?
rabies shield has 3.33
Okay.
international units per kg,
Okay.
and twin trap is 40 international units per kg. But sometimes you can have multiple bites over the body, and you may have it difficult to sort of
Yeah.
infiltrate everything. So every bite, then you can dilute.
Yeah.
You can dilute and then use for all the wounds. So having said that, if you remember the first question, what you should do, especially in children, you should also look at the entire body.
Yeah.
There could be hidden wounds which the child might not have reported. So that is also important.
So I think that is where twin wrap gives advantage over everything else, because the potency is considered to be pretty high. So you can dilute it at a greater level and infiltrate multiple wounds. Normal saline.
Normal saline.
So a quick fire question to, I think we'll ask Danya ma'am first. Rat bite to be given post-exposure prophylaxis or no? Yes or no?
Domestic rats, no, because rats die instantly due to rabies.
How do we know it's domestic or no?
I mean,
Question is-
household rat. But if
Okay.
it is, say, the bigger ones, wild rodents,
Okay.
or what do you call it? Bandicoot, correct. So then you would require.
Okay. Next rapid fire is to Samir sir. A human has bitten me. The picture and the question has no correlation. It's just put considering the emotion what most of the world is feeling. Human bite, do we take or no?
No,
Okay. Unless the
unless you know the
person is behaving rabid. Okay, sir. Huh? Not yet. Not yet. Okay.
You might have some additional tariffs for operating.
No, we are making sure they don't. So,
Remember this, if the person has been bitten by a rabid dog or he is
yeah.
taking vaccine, then
Yeah,
I think
then
should
you
as a
might
SAF,
have
you
to
should-
consider. Yeah. Next is a very weird question to Dr. Dhanya, and obviously this is something that I don't know why, but we keep on encountering pretty regularly. Patient has a bite in genital area. Obviously, I can't put the photos in case you guys were expecting it. Can I infiltrate twin rab locally? Say it is a scrotal area or a vaginal area. Can I infiltrate? I don't know how much amount of twin rab will get infiltrated. So what should I do in such cases?
So that's a difficult question for me also to answer, but generally what is, the rule is actually you must try as far as possible. So even in genital area, there could be areas where you can easily infiltrate using maybe thin needle. We had one on the lip.
Yeah,
and then,
that is again a difficult
just
place.
2 weeks back, it was just inside the lip because the child tried to kiss the dog. Now, we did do it with an insulin needle. But at the same time, if it is just not feasible, then the second advice is to give in the nearest anatomical feasible site. So it could be on the eyelid. These are all difficult sites. Then inside the eye, you can put like drops. You can ask the person to rinse the mouth if there is mucous membrane. Even if it goes into the stomach, no problem. The other difficult sites is the fingertips, earlobe, nasal bridge, because here it can cause, at least in the fingertips, it can cause compression syndrome. So you need to be sort of very careful that you are not causing compression syndrome, but at the same time try to infiltrate in those areas. So otherwise, it is the next feasible anatomical site.
Sure. Next question is to Sameer sir. In terms of documentation of patients coming to you with maybe say previous animal bites, what are the challenges that you have faced in your decision making? Because many times when we ask them, they say, yes, we have taken everything. The moment you ask them to show any proof, even though nowadays if you see with the vaccine, a card comes with the vaccine where you're supposed to mention the date of every dose, and the medical practitioner or the nurse who gives it is supposed to countersign. But have you faced challenges and how you deal with it then?
The commonest challenge is to convince the patient about monoclonal antibodies or human immunoglobulin.
Correct.
Because that is, cost is involved.
Correct.
Plus justification. It is very
Correct.
tough. A small scratch,
Correct.
a wound which is barely bleeding, it's very tough to convince them. That was one.
Correct.
But once that is done, your documentation of previous vaccination, if you are planning to give only 2 doses because the patient is vaccinated, you have
Correct.
to be sure that the vaccine was the newer vaccine and not the ones which they have taken
Correct.
in childhood, which was on the abdomen.
Correct.
Next is, if the patient can definitely tell you when he has taken the vaccine, what was the situation that time, and you are convinced that yes, he must have taken then only 2, otherwise insist that he can take 5 doses and it is safer for him. And third thing we have to be sure about is your OPD paper has to mention that vaccination has started on this date, plus the card which is given to the patient. You have to take all the dates on which he is supposed to take the vaccine, and whenever he comes for taking a vaccine, take that on this day the 2nd dose, 3rd dose is given. So that itself is necessary. Plus you are supposed to fill the whole of the card where they have mentioned the type of bite, site
Yeah.
of bite,
Yeah.
severity of the bite, everything.
Yes.
I think we should fill it on the card, but it should also be on your OPD case paper.
Okay.
Because the card may be lost
Yeah,
by the patient.
that is true.
And then you don't have any documentation of it.
Yeah. So suppose if patient comes telling you a detailed history, but the documentation is not there, would you still consider as re-exposure or treat it as a fresh case?
I would treat it as a fresh patient.
Because
I will give him a choice that if you are going to take a vaccination from me,
Yes.
I would start it from the
Okay.
beginning.
What about the other 2 animal bites we get it, cat bite and monkey bite also we get it?
Yes. So rabbit, horse, cat.
It is the same.
Yeah, it's the
Vaccination is
same. Monkey.
Here I would like to defer. Rabbits generally don't, rabbit bite you don't need. There are certain animals where you can play safe. Birds, for example, because of the difference in the body temperature, birds don't transmit rabies. Reptiles don't transmit. So if you have a snake bite, you're not going to give rabies vaccine. You get, there are turtles in the houses nowadays, so that also you don't need to give rabies. But definitely monkeys, stray monkeys, dogs and cats, and wild rodents, yes.
Horse, I had 2 cases.
Horse, I'll have to check and come back to you.
No, horse, you should. I think you should not take a chance.
Yeah,
I have
horse,
one
you
more-
should not take a chance.
You should not take a chance.
That's true.
Because the horse can very well
Horse
be
can-
bitten by a dog which is rabid.
Right, because
and
there was a
then you should
case
not
in
take-
Kerala where it was the horse that had caused a problem. And then they had tracked all the contacts of that horse on a beach. There was a horse. So definitely
Vaccinated
yes.
everyone.
Yes.
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 Yes. Yes. We'll take questions in the interest of time. We'll take questions. don't worry.
One addition which I wanted to make, because we have seen the patients. A patient had come to us afterwards when he developed rabies. History was, he was walking on the road, dog was sitting in a pool of water which was there in the rainy
Yeah.
season, salivating.
Okay.
The person slipped because he was scared of the dog, went into that pool, the abrasion
Open
of the
wound. Yeah.
elbow.
So that.
He
yeah.
went to the hospital, took a tetanus toxoid, and he was advised not to take anti-rabies because he was not bitten, and I don't know, the person there did not believe. After 3 months, patient came with frank rabies symptoms. So even this sort of exposure should be covered.
Should be taken care of. So one last question to Dr. Dhanya. We have seen all this. Is it safe to give in pregnant females and immunocompromised? Any documentation
100%.
of
It's life-saving. There's no
complications,
contraindication. Definitely
adverse
not.
effects? Okay.
Definitely not. But one point I just want, which has been missed, is that rabies vaccine should not be given in gluteal region, because this is
Yeah.
a mistake that we have seen. It is either on the deltoid or in the anterolateral part of the thigh.
Correct. Correct.
Sir, if the patient misses the second dose, like third one, and he comes up on the third dose, so we calculate from the last dose base or from the first dose?
The second dose.
Second
is-
dose.
The third dose was to be taken after 7 days.
Correct. And the patient,
Comes late. So like
the next dose will be as per the schedule
Yeah.
only. You follow the schedule. So that will be like 14th days after the 7th. After the
second या third dose को first dose से ही calculate करेंगे, suppose second dose miss हो गया, तो जब वो late आएगा, तो उसका third dose suppose
No, the late dose you give it when the patient has come to you and you stick to the schedule. You have already calculated from day 0. You stick to the schedule. Yes.
schedule should be met. Correct.
Seventh day, or dose of schedule on third day. He has not missed that. So what should we do?
He's taken day 0, he's taken day 3.
No, not taken 3.
Then it's
Goes on the 7th day.
it's failure. Yeah, so it's failure then.
second dose के लिए 7th day पे आया.
If the third dose is taken on the 7th day, then you just
No, he has come for the second dose on day 7 instead of day 3. Then
yeah,
it's,
so day 3 dose on day
Yeah.
7. Just continue the schedule.
yeah,
Then he misses on a dose.
yeah.
No, you give all the 5 doses. It's just that there is a gap of 7 days.
नहीं मैम से 7th day पे वो second dose के लिए आया.
Correct.
Got it.
Correct.
So your third day is on day 7, and then after 7 days the third dose. After 14 days the 7 days 14th dose.
You have taken the dose 1-0, the third dose, the second dose you have missed, and you have taken the 7th day. What about the third dose?
After 7 days.
How it should be rescheduled?
It should be rescheduled. You give, yeah. As
If
per
you
the
miss 2 doses, then you should restart the vaccination.
Yeah.
Other catch is, many times a dose is given intramuscularly, either first dose, second dose, third dose, because the sisters can make mistakes. I had a patient where my hospital staff had only given a second or third dose which was intramuscular. So we had, or 2 doses were given, we restarted the vaccination, convinced the patient that we have made a mistake, that 2 doses were given intramuscular, so we will restart the schedule. Intramuscular, intragluteal, sorry, gluteal. No, gluteal. Instead of a deltoid, it was given on gluteal. I know. This is on paper, but it can happen practically that the staff which was there to give a injection was given. That is fine, but I cannot compromise the patient. I will compromise my staff's whatever it is. But when the patient's condition comes, patient has missed 2 doses, so I have to restart the schedule. I may pay for the vaccine, that is different. But the patient has to be convinced.
Okay, fine. You will do whatever.
Yeah.
But normally, like your staff and you have a coordination. You write a prescription on the day when somebody.
Yes. That is all is written. But what can happen practically, I am telling you.
Even if you write a detailed instruction, it can still.
On the gluteal region, that dose has to be considered as a skip dose.
Okay. Yeah. So I think we close the animal bite session before we start biting each other. Can I request Dr. S.V. Kulkarni sir to come up on the stage to felicitate our champion and panelist? We'll start off with Dr. Dhanya to be felicitated. Trust me, even if I put 50 questions, it's not going to be. We'll do one by one. Felicitating Dr. Girish Moharid sir. And felicitating Dr. Sameer Sahasrabuddhe sir. Sure.
I just want to add something very practical to this. This type of rabid dog bites don't happen by appointment. So they come on Friday evening, Saturday night, or early Sunday morning. The Khopoli, Karzat and Panvel people have got a lot of farmhouses. तो उधर सब लॉर्ड फॉकलैंड के लोग रिलेटिव्स रहते हैं, पार्टी हो जाती है, बाद में समझता है कि किसने तो बाइट कर दिया है. So please find out somebody who stocks the vaccines and the antidotes. Because otherwise, I remember a person, I had sent him to Bhiwandi, go down to pick up the dose. Otherwise, everything is delayed to Monday morning. So the timing is very important, and ask your nearby pharmacy to keep the things available.
Thank you, sir, for the insights. Looking at the time, I was having what our next session is. So I think the commonest problem what we have in our hospital is heart attacks. Yeah. So let's start with how do we deal with it. I know there's going to be a lot of questions. I've tried to limit it to what major challenges we have. Can I please invite the panel on stage? Dr. Brajesh Kumar, Senior Cardiologist, Apollo Hospitals. Dr. Kalkekar would join us in 2 minutes. Dr. Mahesh Gogre sir, Senior Cardiologist. Dr. Charan Reddy, Cardiologist, Apollo Hospitals. So, actually, why don't we invite an ortho to deal with heart attacks? That would be fun. Okay, so because Dr. Kalkekar is yet to come, I'll start with Dr. Charan. What are the typical symptoms of heart attack? This symptom, it is heart attack, there is no doubt.
It's on?
Yeah.
So the typical symptoms, there's nothing like very typical symptoms in heart attack, okay? So, but if you go by the data, the most common is chest pain, okay? Or there's breathlessness. Chest pain is typically radiating to the left side, to the jaw, okay? So this is what classical symptoms of heart failure and heart attack is. And the most important is that the pain is crescendo. That means it is lasting for about 10 minutes. So it's going up and up and up. So it is irrespective of you, it increases on walking. Even if you're resting also, there's a pain. So this is very classical of what is heart attack chest pain, rather than what we have is GRD chest pain.
So we know the typical one. So my next question is to Dr. Brajesh. Typical one, most of us are aware of it. What is atypical symptoms? Gas hai, ye hai, how do we know? Because when we call you, you ask the same, typical or atypical.
So if a patient has got a gastric symptoms and is associated with symptoms like anxiety, diaphoresis, uneasiness, now then you need to be very careful about it. If a patient is coming to you at 2 o'clock in the night with dyspepsia, trust me, you need to take it very, very seriously. I mean, if a patient has got a gastric symptoms associated with fluctuation of heart rate, fluctuation of vitals, blood pressure, and you find that the patient says that this type of dyspepsia has never happened in my life, trust me, you need to take it very, very seriously. If a patient has got dyspepsia symptoms in the upper chest, then please don't take it as a dyspepsia until unless you rule out this. I feel dyspepsia symptom, acidity symptom should never be sent back at odd hours of the day until unless you evaluate this patient. If you have a patient who has got a very strong comorbidities like diabetes, younger brother or younger sister, older brother, older sister had a stent in the past or bypass done, or parents have a coronary artery disease. I mean, if you have a very strong comorbid condition or you have strong risk factors, please don't take dyspepsia lightly. You are missing something. Odd hours a day, don't send these patients home.
So my next question to Dr. Mahesh, what is a silent heart attack?
Basically, silent heart attack means patient does not have any symptoms, or he can have minimal symptoms, or even if he has symptoms, they go unrecognized. These patients typically have atypical symptoms. Basically, it is common in elderly patients, female patients, particularly post-menopausal patients, and diabetic patients. So basically, they can have any sort of symptoms, any pain or any discomfort ranging from lower jaw till umbilicus. It can be related to heart. So sometimes these patients present with gastritis, diaphoresis, hiccups. Hiccups is very common. In case of inferior myocardial infarction, or those patients who have got RCA infarct, that directly lies on the diaphragm. So it can cause irritation of diaphragm and hiccups. This is common. Dizziness, when patient have heart rate changes like bradyarrhythmias, patient can have intermittent dizziness. This is very important. I have got one patient, he was being treated by orthopedic surgeon for 3 months for right tennis elbow. And that was when he tends to walk, he had that pain. That turned out to be a critical RCA occlusion. Patient was from Vasai. So we have stented RCA and he is absolutely fine. So last 3 months he was being treated for tennis elbow. So any pain could be related to heart unless proved otherwise. So if patient has any symptom that is exacerbated by exertion, or particularly after taking meals, postprandial angina is again very atypical symptom. Patient typically complains that I get heaviness in the chest or back or shoulders after taking meals. Typically it starts 5 to 10 minutes after meal and tends to there for another 10 to 15 minutes. So atypical symptoms are very common in silent heart attacks. So this is more dangerous as compared to STEMI, because STEMI gives time and recognition. So these patients generally land up with heart failure, arrhythmias, and they suffer with chronic heart failure.
What about the sweating?
Yes.
Sweating is, yeah, sweating is very common.
So I think the first thing we are going to do with such symptoms is do an ECG. So my next question is to Dr. Charan. What are the typical changes in ECG which will clearly point out that it's okay, it's a heart attack? The obvious ones.
Yeah, the most typical finding that you see, first you have to see whether there is a STEMI, that is ST elevation myocardial infarction, or an NSTEMI, that is non-ST elevation myocardial infarction. Any new onset LBBB in a patient who have a normal ECG prior, you take it as an heart attack. Okay, that's the most important thing. And the second most important is that if patients have tall T waves, that's the first, and also called hyperacute T waves. That's the first change that you see in a patient just going into STEMI. And apart from that, what we have is the other things like U waves. Okay, so these are the most important things that you have to look in patients with changes with this thing. Yeah, that's it.
So the obvious ones are easy to pick. So my next question is to Dr. Brajesh, and this is something which we keep on fighting with him. So ECG is normal. Does that rule out?
Yeah, so if you see literature, am I audible? Yeah. If you see the literature, 5 to 7.3% of the patients will have a normal ECG at the time of MI. So that does not rule out MI at all. See, myocardial infarction cannot be diagnosed based on only one thing, which is ECG. People think troponin, people think history. So all these three things are important. I consider history taking is the most important step in diagnosis of myocardial infarction. Now, there are certain conditions in which the ECG will not have a typical findings. For example, if the patient has reached quite early, you can have only hyperacute changes which can be missed. You can have only tall T waves, so that can be missed. Number two, sometimes the ECG will have a dynamic changes. Changes will come and go, changes will come and go. So by the time the patient has come to you, the angina is relieved, the ECG has become normalized. So that is second thing. Certain conditions where few changes are missed, for example, in the presence of right bundle branch block, in the presence of left bundle branch block, it is sometimes difficult for a common doctor to diagnose MI because there are certain criteria to diagnose. The ST elevation has to be more than 5.5 mm in case of LB. So there are criteria. If the patient has got a severe tachycardia, then also it can be missed. For example, patient has got AF with fast ventricular rate. You may miss the transient or significant STD changes in these conditions. So these are the situations in which you may not feel that the ECG is typically showing heart attack changes. There may be hidden changes in that. So it's important that not only the ECG to be taken care of, also history has to be taken care of. And of course, the troponin you cannot rely always on the time because they come only after 3 to 6 hours. So if you have done a troponin and based on that and ECG normal, you send the patient home, the patient may come back to you or may not come back to you thinking that मेरा तो heart attack rule out हो गया है, अब तो मेरी acidity है, and he may die at home. So that is the situation. In odd hours of the time, even if your ECG is normal, I still advise you to repeat ECGs, make sure you properly evaluate the patient, then only send the patient home.
So my next question is for Dr. Kalkekar. So a lot of us have heard about the Apple Watch alert. Apple Watch alert. And nowadays you have more smart watches which are actually trying to diagnose it. So what has been your experience and how reliable are they, whether for heart attack, for arrhythmia? Should we rely on it or we do our routine?
Actually, very good question. First benefit of Apple Watch is that it has increased our practice by 10%. Because a lot of people come on non-specific theme, Apple Watch shows something, Apple Watch something. One thing what you remember is that Apple Watch algorithm detects heart rate, that is the rate, and second it detects the rhythm. So if the heart rate is like more than 100 or less than 60, it will definitely detect. So rate will be detected, rhythm will be detected. So most common rhythm is atrial fibrillation which is detected. So if the person has atrial fibrillation, that will be detected. Now considering MI, it will not detect whether patient has a ST elevation MI or only case if he has a VT, it will detect, but that is the last time. So by detection, that VT is not significant. So I will suggest definitely if you are using Apple Watch, use it, but don't believe Apple Watch for diagnosis of STEMI. I think over the period that will come. Like in when you do the Holter, we can see the ST elevation, transient ischemia can be detected on the Holter, but Apple Watch at this moment, till this time, they cannot detect MI. They will detect rhythm and rate changes. That is the only thing important.
Okay, thank you. My next question is to Dr. Ghogre. Dr. Brajesh mentioned something about troponin. This is a very common disease amongst people in emergency and I assume all nursing homes. We have troponinitis. We do troponin if patient says chest pain, but we don't correlate. So what exactly is troponin and how does it help us to diagnose heart attacks?
Basically, troponin is routine for us. We have got many small devices. We use CPK, troponin, D-dimer, and antiproben. So when it comes to the detection of heart attack, it should be high sensitive troponin I. That is HS stop, what we advise. So there are different protocols. Basically, for HS troponin to rise, it takes almost 1 hour to 3 hours. There are no machines as of now those who will detect troponins below 1 hour. So any patient presents within 5 minutes of chest pain, we have to repeat the troponin after. As of now, we have got assays with 3 hours. In Apollo, we follow, it takes almost 1.5 hours for routine HS stroke to come. So there are two protocols, one is 0, 3 and 6, and second is 0, 1 and 3. So in Apollo, we are in the world, next week we are going to start protocol of 0, 1 and 3. That means, so it is very tricky. So suppose normal troponin, HS troponin value is less than 19 nanogram per liter. So if patient has initial troponin of say 5, so if there is absolute increase by 5, that is confirmatory that this patient is having acute coronary syndrome. Absolute value means if it was 5 and it has become 10 over the period of 3 hours, then it is ACS. So second is couple of patients with COPD, CKD, elderly patients with chronic heart failure, they have persistent elevation of troponin. Whenever we get troponin for this patient, it is always high, that is about 20. Suppose patient with CKD have 40 troponin value. So in such cases, if there is 20% increase in the HS troponin value as compared to baseline, then that is suggestive of acute coronary syndrome. So all patients who come to the EMS with chest discomfort should get troponin at 3 hours and later on after 6 hours. And if they fulfill this criteria, then it is ACS and we should proceed as per ACS protocol.
Just want to add one thing, the question which you asked to Brajesh. Just recently, last week only, what happened, patient I took for the angiography, on table he complained that I am getting backache. So, okay, we are doing angiography, don't worry. So I done angiography, right coronary it was 70%, L6 was 70%. So I told that we will require angioplasty. He said, no, sir, I want to take opinion of other doctors. That's okay, I will take you outside. I took outside. I done angiography, patient was stable. He just complaining of backache, and during angio also his backache was there. I shifted to the recovery, and I just told my anesthetic to give paracetamol and just wait for some time. After half an hour, he again complained chest pain. I done ECG. ECG was normal. Angio was already done. It was not suggestive of any STEMI. So I just wait for half an hour, then we'll shift this patient to the ward. After half an hour, just while shifting, I just gone see the ECG. ECG was showing ST elevation. Patient doesn't have pain now. Done angio repeat. Angio was 100% RCA. So it's very difficult to detect chest pain. It is a definitely combination of art, commerce, and science. So symptoms, ECG, echo, enzymes, and angiography. So what is our strategy? Any patient non-specific or if patient comes, we do all these 4 tests. I usually admit patient, do the stress test. If it is negative, then you are free. Or in case you do the CT angiography.
So that was going to be my next question to Dr. Charan. Everything is done, 2 sets of troponin is negative. Does that convincingly rule out?
See, as per the latest protocol,
Switch it.
What the protocol other countries use is, 0, 1, 2, 3. This is what because most of them ERs have, facility of troponin I to do on at site. So therefore, they have a very different protocol. And more than rising, it's also falling. Okay, don't only go for rising. Okay, even falling by 5 nanogram per liter is equally significant in patients with, if you have an initial one which is well below the normal limit, and you have the second value which is falling. Okay, that is equally important, not only rising. So we should be, when you're treating STEMI patients. And what else?
I think that would be sensible to take the decision in holistic manner rather than just stick to one set of work.
Don't only go for rising, also see the falling also. That is equally important in patients with STEMI.
Now, being in India, we are lucky to self-medicate, and ChatGPT, Google Gemini helps us to diagnose our problem. So my next question is to Dr. Kalkekar. I have chest pain, should I take Disprin?
This is 100% you take Disprin, but this is a half question. I will suggest you take clopidogrel or take additional Axer and take statin also. And if you have sorbitate, take 5 milligram of sorbitate. If you have BP machine, take 1 more 5 milligram sorbitate after 5 minutes till you reach the hospital. Provided don't consider giving medicine should stay at the hospital. This is just medicine till reaching the hospital.
So what if I have not done a ECG and actually I have gastritis? Will that aggravate my problem with
whatever happens
so much of
at the max? It will. You have a GI bleed. We have greater hepatologist and GI surgeon. They will take your care. Don't worry about that. because heart is more important here.
Okay. So next question to Dr. Brajesh. Sorbate rate, how much of a big fan are you and what should be the limit? Because we have had patients who have taken 5-6 sorbate rates and we were actually worried because of the after effects. So what is your recommendation in taking that?
Yeah, so I think if the patient is feeling giddy, dizziness, or if the blood pressure is on the lower side, better not to give sorbate rate. You may be dealing with an inferior MI, RVMI, where probably sorbate rate may be an issue. If the bystander or the doctor or your general practitioner is available bedside, if he checks the blood pressure and you have a chest pain, the blood pressure is fine, then probably sorbate rate 3 doses can be given 10 minutes apart. But you cannot give all 3 at a time. You can have hypotension at that time. The important thing is to reach the hospital as early as possible. I just wanted to add, there's a lot of confusion regarding troponin and acute coronary syndrome. We often tend to forget one very important entity, which is unstable angina. Acute coronary syndrome is not only ST elevation MI or non-ST elevation MI. It is also unstable angina, which may be just 1 hour prior to an ST elevation MI. So if you have an unstable angina, your troponin is going to be negative. But you cannot leave that. So I've seen patients discharged at 1 o'clock, 2 o'clock in the night just based on 2 troponin negative. I don't agree on to that. Unstable angina is as dangerous as NST elevation MI where troponin is elevated and ST elevation is there. You can have an LAD 99% lesion, the flow is still there, the patient continue to have runs of chest pain, angina. So it is important that not to miss ACS, unstable angina, in the absence of rising troponin.
I agree. Unstable angina is very dangerous. Postprandial angina and unstable angina. These are 2 subsets where all tests could be negative.
So, yeah.
Positive troponin I is significant, negative troponin I is not significant.
Absolutely. Yeah.
So even I think
that will not rule out unstable angina, sir. We are just talking about non-STEMI with troponin.
Overall,
Yeah.
troponin I is confirmatory test if it is positive. If it is negative, don't decide on the.
Yeah, absolutely.
I think if you do it too early on, I think that is what you're expecting.
Basically, CPKMB rises early. CPKMB tends to rise say within 1 hour, but that increases over the period of 24 hours, and after that it tends to subside. But troponin stays there for 7 to 10 days, and troponin stays there for 10 to 14 days. So, if patient presents with chest discomfort say after 48 hours, so still CPKMB may be normal, but troponin will be high.
So is it good to do both when the patient presents?
No, madam, it is not recommended. Troponin is fine. Yes. CPKMB is very non-specific basically. Even patients with extensive sports activity, if patient is runner, if he is running or
They
any
will
sort
have
of muscle
high
activity, that will tend to increase the CPKMB. So that is not, troponin is more specific as compared to CPKMB.
So there's some drug which is better than clopidogrel.
We'll discuss
This is
that. We'll discuss. So
I
I think
just
one
wanted
thing
to add one thing. When is the time when you will do CPKMB? Suppose you had an interval MI, you have done an angioplasty done.
Yeah.
The patient comes back again within 10 days with the chest pain. You know the troponin can be high because of the first episode. But CPK might have gone down, and if there is a rise of CPKMB now, that means it's significant. The troponin rise can be up to 7 to 10 days, and sometimes even up to 14 days. But new CPKMB rise is going to be a significant one. So that is the importance of CPKMB in a patient who has already had an MI 7 days back.
One addition for that sorbate rate contraindication is a sildenafil. If the patient has taken 24 hours before sildenafil should not be given.
So I think one point I'll just reinforce, which all of our panelists have beautifully said it indirectly. Doing troponin, I think, is important, but more important is what is your pre-test probability that it will be ACS. If your pre-test probability is high, then troponin is helping you, either to take it up immediately or electively. We have had sepsis patients who have massive levels of troponin I, but none of them have initiated the cath lab or taken them up for angio. So I think what everyone focused was pre-test probability is equally important. Coming to the next important question, golden period, what is it? Is it golden hour? Is it golden half day, week, month? So what exactly is the golden period that will benefit the patient most?
We say initial first hour is the golden hour. This is the terminology, but that we should take it from the onset of chest discomfort, not once patient reaches to the hospital. So this is very important. So any chest discomfort which is supposed to be ACS, whether it is unstable angina, STEMI or non-STEMI, we should count from the starting of the chest discomfort. So whenever there is sudden occlusion of coronary arteries for initial 2 minutes, then there can be complete recovery if that gets recanalized or if you open. But this is practically not possible within 2 minutes to take the patient on the table and do the primary angioplasty. So if patients gets continuous occlusion of coronary artery for say 15 minutes, still complete recovery is possible within 6 hours. But once that vessel is occluded say for 20 minutes or more than 20 minutes, there has to be some damage. Patient will suffer LV dysfunction permanently in some or other form. So there could be mild dysfunction, but it will be there. So initial 1 to 3 hours, we can salvage most of the myocardium. 6 to 12 hours, still we can salvage some myocardium. 12 to 24 hours, there is very less possibility that we can salvage completely occluded artery. And after 24 hours, there is no recommendation that we should go ahead with angioplasty. So in such patients, if patient is having persistent failure or patient is in cardiogenic shock, still we can think of getting rescue PCI for such patients. So, but if patient is stable, completely stable, and we have got 100% occlusion after 24 hours, ideally we should go for viability scan to look for the viability, whether that portion is viable. And if that shows viability, then we should open that artery. So initial 1 hour is very important. Each and every second and minute counts when it comes to save the muscle.
Yes.
I have genuine practical questions. I have patients with acute myocardial infarction. Yesterday's story. I know that thrombolysis would be a good line of treatment, but better than that would be to open up the artery by the angioplasty. Now we are in a process of transiting the patients to a super specialty hospital, and it normally takes 2 hours. Irrespective of all methodology of calculations. So would I be justified if I give thrombolysis at my place?
I had that question. We'll address it. No issues. So just a quick rapid fire. Golden hour, 12 hours, 24 hours.
24 hours, there is no point. It's 12 hours.
12?
And even in the place where we are, see,
So
the
till
place where we
maximum,
are,
whatever.
the place where we are, if you are planning to thrombolize a 10-hour-old interval MI, I think it's not fair. Forget about 12 hours. Thrombolysis is best done when within 3 hours, 6 hours. But after that, if you thrombolize, you will have an issues. You will have more arrhythmia events, you will have more cardiac arrest, you will have more hemodynamic instability. So I feel by the time you reach 12 hours, thrombolysis is out. Better to shift to a patient place where you have more of a, interventions available.
So we keep it 12 hours? I
If
was
you,
thinking
if
few of you will
you see
differ.
the microbiology of this cell death, after 4 hours, it goes into what is called irreversible phase. Okay, beyond 4 hours, even if you revasculate, the tissue perfusion is not that much, and beyond 12 hours, it's futile. This is what the microbiology says regarding the tissues.
12 hours.
Yes. Yeah, beyond 12 hours, there is no point doing
Sure.
it.
So my next question is to Dr. Charan, like ma'am had asked, what loading doses should I keep with me? Drug, dose, and what is better than what?
Yeah, so a lot of studies have gone to what medication to keep with itself. I feel that keep 325 milligram of Disprin with you, okay, and the sorbitrate probably, along with an atorvastatin. There are 3 medications only to keep them. There's no point keeping 5-6 medications and load yourself with these whenever you have a chest pain. So all the studies have shown the 325 milligram of Disprin, dissolved in water and drinking a glass of water is enough. Okay, to get by, to an hospital where you have facilities for revascularization. Apart from that, if you, you can take a pop in a sorbitrate under your tongue to get through that chest pain phase. 2 medications only. The third additional medication is probably a statin. That is the only thing that I will say as an add-on medication. But these 2 medications should be kept with you: is Disprin and sorbitrate. Only 2 medications.
So you can consider giving half dose those patients who are above 75 years. So there are studies to avoid high bleeding risk, particularly elderly patients, very frail patients, elderly female patients. And generally what we follow as of now is we give ticagrelor instead of clopidogrel. This is routine for us. Even those patients who are loaded with clopidogrel outside, we tend to load with ticagrelor when they comes to emergency department.
Dose.
2 tablets, total 180 milligram.
If we don't have a blood pressure measuring machine at home, should we give sorbitol?
Everyone will differ on this. I will not suggest sorbitate. What do you say, Dr. Bajaj?
If you can feel the pulse well, I mean, if you can feel the dorsalis pedis, if you're a doctor, otherwise also if you feel the pulse well, patient is not having diaphoresis, only the chest pain, probably you can give sorbitrate, at least 1 tablet you can give safely.
At least 1 tablet would make.
Yeah, of course, if you feel that the patient is pulseless, if the BP is, you can make it out, the patient is restless, the BP looks like the pulses are not feeble, then of course, but I will not recommend a layman to give sorbitrate, you know. Your office bearer of a society giving you sorbitrate when the BP is not very well appreciated. I will not appreciate that. But if a doctor, general practitioner gives, I appreciate it. Probably he has checked the pulses and felt the pulses are good enough to give.
Especially in the elderly patient, basically. One of my elderly patients, he had diabetes, he had all the problems. So while going for the Belapur station, he felt the chest pain, he had a sorbitrate, he took it and he felt it there. Luckily people were there and then they shifted to the hospital. Otherwise elderly people taking on their own sorbitrate he fainted on the station, railway station. So it could have been much more serious.
But that fainted is due to sorbitrate or it is due to it? We cannot tell that part.
No, I think
so if the patient has no giddiness, giving sorbitrate is not hampering. That is my point.
So I think only the benefit part is short acting. You can always cover the side.
Inferior LMI patients, they have hypotension and it is contraindicated to give sorbitrate. We can't make it out whether it is inferior or anterior LMI.
So next question is...
Just add on to it, if you give a sorbitrate, don't let him walk again. I mean, it will cause postural hypertension. I mean, even while you are shifting the patient, giving a sorbitrate to a tertiary care center, please make him shift him on the wheelchair. To avoid wheelchair, better to be on the bed and shift it. Because the moment the patient gets up after a sorbitrate, it's like doing a heart test, still training. The patient is going to have a vasovagal, already having a low blood pressure.
Put your name and MMC number entry in the sheet. Your points get automatically updated in your MMC account. In case if any one of you do not have a MMC number right now, please let us know at the point of registration. We'll make alternate arrangements for the certificate and convey it to you. Third thing, for all the delegates who are attending today.
It is full-blown classical picture, there is no doubt. So problem arises when there is an incomplete presentation. Like a Bell's palsy patient presents within a few hours, 1 or 2 days, with a grade 1 or 2 weakness where you have some doubt. So first, history will give us a clue. First, we take a history of any antecedent viral infection in preceding 1 week, 2 weeks. Then they will have some periauricular pain. So these point, history-wise, point toward the diagnosis of Bell's palsy. And in neurology, most of the diagnoses are made by the patients. So in medicine, we say, listen to the patient. They are telling the diagnosis. It is, I think, more true in neurology because sometimes our investigation may not show anything and patient is telling anything. So history is more important. In Bell's palsy, onset of weakness, of facial weakness will be slow, gradual. In stroke, it will be within minutes. So that is more important. Then third thing is associated signs. In Bell's palsy, upper face is generally involved. If you ask the patient to look up, in element facial palsy, the one side furrow will go. In stroke, it will be preserved. And platysma, then again, it will point toward the element type of facial palsy. Then another 2 important clues, ask for the taste. Suppose it is lost, again more in favor of element facial palsy. Sometimes stapedius involvement, they can cause hyperacusis. So these are the points which points toward the element facial palsy. In stroke, sometimes the facial weakness may mimic like a element, grade 1, 2 element facial palsy, but patient will have more of a dysarthria. Bell's palsy patient will not have that much dysarthria. And again, look for the subtle signs, like in such patient, they will not have classical hemiparesis, but if you ask carefully, there will be some draped. Clinically, you may have some upgoing plantar. So these points favor more in favor of stroke. Now again, third dilemma, suppose element palsy because of stroke. So it will be like a stroke only, But a patient having LMN palsy because of brainstem stroke, he will not be stable. He will have associated symptoms along with other cranial nerves. You will have plantar going and all. And so these are the things clinically you can do. And suppose the patient, still you are in dilemma, there is no harming doing MRI and ruling out any other, ruling out stroke in emergency. So we can avoid by doing clinical examination.
So my next question is to Dr. Parikh, sir. So my patient has come to me after a history of loss of consciousness. History-wise, I feel it could be a syncope. Should I still evaluate him for stroke?
Well, it all depends upon the clinical picture. What is the age group of the patients you are facing it? If you go down back into the history, whether the fall has occurred because of some reason or because of non-known reasons. If there is a clear-cut history of diabetes, hypertension, or otherwise ischemic heart disease or an atrial fibrillation like things, and if the patient is in the age group of 60 plus, I would definitely keep all my windows of the mind open, not only for the stroke, but also for the metabolic disorders as well as infectious or sepsis disorders.
So if loss of consciousness was one of the challenges that we face most of the time, the next is my question to Dr. Kaushik is patient has involuntary movements, seizures. And if I may take the liberty, sometimes they'll end up with something which we call as Todd's paralysis. So should we be over-evaluating a post-ictal patient or should we not suspect stroke in those?
So again here we should have proper history with proper examination. Patient may present with some involuntary movements like hemibalismus, hemichorea. So we have to assess clinically according to that. Sometimes patient may mimic like hysterical, some tardive movements like in cases of some drug abuse or in some drug side effects like haloperidol or there are metoclopramide. So these drugs may cause involuntary movements. But with the subside of, with history, with subsidence of the additional factors, if the movements associated with single-sided sudden weakness, history is important. So in cases of involuntary movements, they may last long for more time. But if history suggests that it is sudden onset, one-sided involvement, with positive signs of strokes, then we may consider the both occur same time. But it's very unusual. Secondarily, we can also see the scans if the patient may present with within golden hour, that is 4.5 hours, then we can suspect some involuntary movements associated with the stroke. Yeah.
So I think one thing which we miss working in corporate hospitals is ether. I think all of us have worked at some point of time in a government setup and used ether and Ryle's tube, abused ether and Ryle's tube on our patients who are unconscious, right? Have you or have you not?
I think
you still feel you should do it.
That's only used in government hospitals.
Yeah, so we miss it in corporate hospitals. We don't dare to use it. So my next question is to Dr. Shekhar. Is there anything called a psychogenic stroke, functional stroke? Imaging is normal.
So you can have an MRI negative or imaging. Most of the time CT scan is normal in terms of the initial part. Unless and it is a large stroke, you can actually pick up some subtle features. MRI can be negative. Posterior circulation strokes, we know that they're lateral medullary, very common to miss out on the MRI. So I mean, the part here is about the clinical examination, and you should probably be looking at examining the patient in different settings and different positions. And if you can elicit that in a particular position that movement is not possible, but in other it is possible, then you can probably, so but then that is something but probably will be last. In an ER setting, probably you would take it as an acute stroke, and functional stroke will be after everything has been done, and then you come back and say that, okay, you may get a history that someone has psychiatric symptoms, he is on medications, then probably you would think about it. But presenting as a first thing as a functional psychogenic stroke, probably not very.
My next question is to Parikh sir. So, you have a patient of stroke, you clinically feel it's a stroke. Do you take the risk of giving ecosprin without doing any imaging?
Now again, it all depends upon which setup you are working for it. If you are in setup like this, you have all modalities in the life, all time on your side to decide whether if the patient has got a bleed or patient has got SAH or otherwise transient bleed, then of course giving ecosprin would be harmful or any other things. But if you are in a setup wherein you are supposed to act and the CT scan modalities are far away from you, from your clinical judgment, if you can rule out hemorrhage or progressive decline in the level of consciousness, progressive increment of the CNS symptoms, which would otherwise point up to either an hemorrhage or this thing, some from your, and as well as looking at the age group of the patients, what we are dealing with. If he has got associated metabolic disease like diabetes, associated cardiac functions or associated atrial fibrillations, there is no harm in giving ecosprin.
So my question comes from one of the situations we had. We had one of our fellow doctors in Navi Mumbai itself having headache followed by unilateral weakness, and actually he took ecosprin. Unfortunately, by the time he came to us, he had a massive bleed. So it was always a bleed. Unfortunately, it just aggravated because of the antiplatelets. So that was my reason of asking questions.
These are a bit uncommon things. So most common things would be that we are also at times in dilemma whether to go for the CT or MRI. Again.
Correct.
So, I mean, it's a
so common things first, uncommon later.
Absolutely.
That is best way to do it. So if we are talking of antiplatelet, I want to ask Dr. Kaushik, do you aggressively lower the blood pressure before actually diagnosing what exactly it is, ischemic or hemorrhagic stroke, or do you want to wait and watch till the imaging is done?
So we should not lower the blood pressure unless and until we diagnose the case by doing thorough examination. Or if we do have a time certain setup, then go ahead with imaging. So always it is strictly said that not lowering BP and confirming with the diagnosis. But if the guideline says if it is more than 220 systolic, then you may reduce the blood pressure up to 180 systolic or 190 systolic. So 185, some say 190. So by reducing the blood pressures, if the pressures are more than 220 by 120, then we can go ahead with imaging and scanning, and then diagnosis. If it is not bleed, we can, if it is infarct, we can reduce the blood pressures according to AHA guidelines, 185 by 105. So if it is bleed, intracranial bleed, then the recommendation is reduce the blood pressure, but not within 24 hours by 15%. Then afterwards, the target achievable BP in cases of intracranial bleed is 140 systolic.
So if it is not very aggressive, but in a
controlled manner with a controlled time. And the answer for you at the last question to sir was never try to become own doctor of yourself. My fellow who did the same thing, without checking the sugars, he had ecosprin and he landed up with a massive bleed. So that was very bad thing.
That was unfortunate.
So most of the time, we can say 90% the intracranial bleed may remain, may present with the comatose condition, most of the time. And in fact, may present with the level of consciousness. GCS may vary, but there is a history, the patient may tell history. Second thing, it is unilateral with some positive contradictory signs with the infarct. So those we can differentiate with some clinical examination.
How to lower BP?
So if it is more than 220, it's impossible to lower in a clinic setup. You have to admit in ICU, and we have to start with injectable labetalol or nifedipine.
Nothing to be given in?
No,
you-
ideally you should not, because if the BP goes sudden down, then it's very difficult to manage in clinical setup. So always go ahead with
Dr. Vishal
ICU.
wanted to answer that, I think.
In acute stroke, blood pressure rise is actually nature is trying to increase the blood
Physiological
pressure. So there is actually collaterals, and if we are not doing any thrombolysis and we are just managing conservatively, don't reduce blood pressure, because ultimately nature is trying to increase the blood pressure to give the supply. Improve the blood supply. Get imaging done, get confident that it is ischemic stroke. And if you are we are not planning any treatment, don't reduce blood pressure, because reducing blood pressure in such patient, we are increasing the infarct volume. And if you are planning treatment like thrombolysis, thrombectomy, then we are going to reperfuse the vessel. At that time, we should reduce the blood pressure. Medicine, generally we prefer short-acting medicines like labetalol. It is a drug of choice in our setup. We give loading dose, we can give IV, and we can always also switch over to tablets. So we have all options possible. If it is not available, we avoid NTG and all. Then other options will be enalapril and nitroprusside we don't have. But in emergency setup, then we use NTG, but we avoid, and we give labetalol is the first choice of medicine.
Within 4.5 hours, if we try to reduce the blood pressures, or in a golden period, that what we say, then it may leads to increase in penumbra also. We further damages the brain tissue.
My next question is to Dr. Shekhar. After seeing so many strokes, I might be hated for this to ask him, where should I show if I feel I have a stroke? I have no conflict of interest with all of you. It's just we want to help our patients the best.
So, stroke ready hospital. So, if you actually suspect that so one is awareness. So, okay, you should have an awareness that what the symptoms that I have probably indicate a stroke. So, a stroke ready hospital is somewhere where you are actually received, you have the facility for CT scan, you have the facility for the MRI, you have an ER facility, not just a casualty. So, the ER facility.
I like that, emergency over casualty.
Yeah. So that part, and then you should also have intervention. So Vishal is here. So what we have is, if you have a scenario where you require any of the procedures, then you have everything under one roof, and you have the time on your side, because the golden hour, I mean, it's not like a golden hour. The golden period is 4.5 hours for us to thrombolysis. And then if I want to go ahead and extend it further and do thrombectomy, then everything is under one roof. So that is probably what we're saying. So it's not necessarily a stroke ready hospital, but it's a stroke ready unit with the facility to do everything under one roof.
So that comes to the next question, which I want Dr. Vishal to answer. What is the golden period? We discussed that in STEMI. So what is it? Is it 6 hours? Is it 24 hours? The latest updates have confused me. It's even beyond 24 hours, I feel.
The brain is more sensitive, so window period is very less. Because if we don't respect the window period, we end up having more damage to the patient than benefit. So golden period for thrombolysis, everybody knows it is 4.5 hours. So onset of symptom to the giving the medicine, that is the time we calculate, it is golden period. For thrombectomy, we have guidelines up to 24 hours, but it doesn't mean that all candidates in extended windows, they are the candidates of the stroke. So ideal situation for doing thrombectomy is less than 6 hours still for best outcome. Given a chance, if patient comes and large vessel occlusion, I would not wait, I immediately will try to shift, and because earlier is again better. But if it is more than 6 hours to 24 hours, we have now guidelines, we can do thrombectomy up to 24 hours, but we should establish the penumbra. So we have to do MRI, and then we should see diffusion flare mismatch. And again, there are certain, there are perfusion studies. We don't do regularly, but we have softwares to calculate penumbra mismatch and core volume and infarct ischemia volume. So golden period is again 4.5 hours and 6 hours, but in certain patients up to 24 hours we can do thrombectomy.
So now that we have established the golden period, my next question is to Dr. Parikh sir. What is your preference, CT or MRI for stroke?
Again, this is a brain teasing questions. See, by and large, if you suspect hemorrhage, CT would be a better.
Yes.
But we, in our practice, when we are not sure of the things, we tell the radiologist to first do CT scan screening rather than taking it. And if there is no hemorrhage, we tell them to go ahead with the MR angiography. And MR angiography gives a better results for this thing, but it is time consuming as well as complicated, but it gives you precise lesions for your subsequent line of action. Similarly, CT scan of the brain, if you have a clear-cut bleed, there is no point in going for further. You have a directions to go for that thing. So I suppose we have to take a judgment accordingly.
Dr. Vishal, you agree with it? Being an interventional neuro, you would prefer MR most of the times over CT, or?
Here, we have Liberty in Apollo. We have MRI and we have protocol where we can finish MRI without wasting time, and MRI stroke protocol can be done within 12 hours, 12 minutes. The duration of our sequence is 12 minutes. So we don't waste time in getting MRI done. But most of the guidelines, they don't differentiate MRI and CT, because initially most of the guidelines were based on CT, but now MRI and CT both are equal. But suppose I am taking time for MRI, so don't waste time, get CT scan done, thrombolize, and if you are expecting large vessel occlusion, then don't wait for creatinine, go get CT angio done or MR angio. Again, sir mentioned MRI is definitely some time consuming, but we get better information. So it helps in better treatment planning and prognostic counseling family about further prognosis.
Next question is something which is a paradigm shift for all of us. If you're aware of it, I'm most happy, because if that much level of awareness has percolated. We had heard this concept of minor strokes in the past, and now with the recent update also, and that this was something which we were practicing before also, there is something called a concept of disabling deficit. So my question to Dr. Shekhar, what is the difference? Minor strokes, disabling deficit.
Go back to the earlier question also. So just a CT scan should not be, it has to be a CT plus angio. So if you really want to choose a CT scan, it has to be CT brain plus angio. And the MRI, the betterment is that you actually are looking at stroke mimics. So the MRI will help you for the stroke. Let's say you have actually a hypoglycemia, where we have always burnt our fingers actually thrombolizing hyperglycemia or hypoglycemia as a cause of the weakness. Correct. Then the CT will definitely miss it. So that's the advantage. But CT and CT angio is good enough to thrombolize. The other part is about the shift in terms of the MRI. If you actually do a CT scan, probably you'll be more keen to do a thrombolysis. Do an MRI, you see something different. The only advantage is you'll probably take him for thrombectomy, but you'll minimize the thrombolysis. Now, with regards to minor strokes versus disabling deficit, so if someone is a right-handed individual and actually is working and has to, it's important for him. Of course, right hand is important for most of us because we are right-handed. So that one, you will definitely, even though the NIHS score may be less, you would still thrombolize. Someone who comes with a posterior circulation stroke, just a vertigo, but cannot stand, cannot walk, then you would actually thrombolize. So you're actually moving towards not just the NIHS score, but trying to understand the deficit. So if it is left-sided for a right-handed individuals, you may probably err on the side of just giving him antiplatelets and not thrombolizing. So that way you would probably segregate the importance for that particular function based on the profession, and then you would choose.
So I think we have had a couple of cases where the patient had MRI stroke, NIHS 2, but there was no disabling deficit, and we conservatively treated
the vision part also, someone having a visual.
So that is something which you will have to look for, because till now we were very hell-bent on the scoring system. NIHS is basically your stroke scale where everyone assesses the patient on the same parameters. So it helps you to trace what has been improving or what has deteriorated. Now, if you see the strict guidelines, NIHS more than 4 follows for thrombolysis. But you can have disabling deficit like only vision loss with NIHS of 2. So this has been a paradigm shift with all of us. We'll have to keep a watch on and not pass it off saying NIHS is less than 4. Let's not do anything. Okay. Next question is to Dr. Kaushik and Dr. Shekhar again. Agent of choice, altiplase, tenecteplase, your preference and the guidelines.
Guidelines says always altiplase, but preference
that is where the googly of 2026 comes. So they have
but
approved
preference
now,
is easy
yeah.
to calculate with the dosage with the 10 hectares. And it's been, usually we are using the 10 hectares only in cases.
Dr. Shekhar, your experience?
So actually everyone is now moving towards 10 hectares. The only the disadvantage with altiplase is 1 hour infusion. So
Yeah.
you're wasting that 1 hour, where with the 10 hectares it's actually just a bolus and you just finish it off. So you can actually even documentary canalization if you
Yes.
are interested in doing that.
Correct. So we heard Dr. Vishal say about mechanical thrombectomy. So what exactly is mechanical thrombectomy?
Mechanical thrombectomy is a powerful tool now we have available for stroke treatment. Within window period, if we do it, actually it makes a wonder. We had a patient last time with a young lady, elder, 52-year-old, middle-aged lady with a large M1 occlusion. Within 1 hour she came, and day 3 we discharged without any deficit. So that is a wonder. It can be done with the mechanical thrombectomy. So just in brief, mechanical thrombectomy is a procedure where we do first document DSA, angiography. Angiography is done under local anesthesia. We use radial, or for thrombectomy, suppose I'm planning the groin is better, femoral approach. It is done under local anesthesia. We do angiography. We document there is a vessel occlusion. And once I know that patient is going to need thrombectomy, MCA is occluded, or basilar artery is occluded, vertebral and junction is occluded, then we plan thrombectomy. Suppose patient is stable, not moving, I can do under conscious sedation. But suppose patient is moving, then I do under ventilator, or if large stroke, then I put patient on ventilator. Otherwise, I do under laryngeal mask airway, where after procedure I extubate the patient. Here I take some diagnostic catheter, then I take my large catheter, either they are balloon guide catheter or large sheath into the carotid artery. Then I enter the occluded segment with the help of microcatheters with microwire, and we use stent retriever where we catch the clot, we occlude the vessel by, there is a balloon guide catheter, it occlude the vessel. And with negative suction, we remove whole assembly and we suck out the clot. Most of the time, I would say 70-80% time, we can open the artery within 20 minutes or 30 minutes in first pass. Another option we have is thrombosuction. We call it penumbra device, where we engage the clot. We take our catheter just at the mouth of the clot and we attach to the penumbra pump, and it will suck out the clot. We have different catheters for large bore catheter for the carotids, and some catheter which can go up to the M1 segment, and also up to M2, M3 also we have small catheters. Sometimes we have to use both techniques. Sometimes the burden is very high, and sometimes the suction may not work. So I take the aspiration catheter up to the major vessel, like MCA, suppose there is, I will take it to the M1. I will take the solitaire also, and both I will do the suction there, and I will remove the clot. So thrombectomy in first pass we can achieve TK3 flow in almost 80-90% patient, and some 10% patient they take some time. But again, timely done, it makes wonder. Sometimes I do thrombolysis and I take patient for thrombectomy, and I realize that artery is already open. We don't do thrombectomy, we come back. Sometimes we do thrombolysis and we take patient for thrombectomy, and I see that there is no collateral at all. That part is totally gone, some out of window. We sometimes don't deny thrombectomy also. So some decisions for thrombectomy, whether to open vessel or not, are taken on table also. But timely done within window period, it is a very safe procedure, and we can do. We have a liberty here. We have cath lab, 2 cath labs available. Every time patient comes, 1 cath lab will always be there, and we always have that pathway, stroke pathway here. And then we have CT scan in our cath lab. So once thrombolysis is done, before and after, we can do CT scan to document that any harm we have done or not. And then sometimes large stroke, we keep neurosurgery team also standby. So everything can be done, provided patient comes in window period and there is a penumbra.
So let's say that some of us have diagnosed it as stroke clinically, CT is negative, we have thrombolized, and there's no improvement. Then is there any challenge for you to take it up for mechanical thrombectomy, since fibrinolytics have been recently given, risk of bleeding
actually,
and all?
Guidelines say if patient is, suppose a person come with M1 occlusion within 4.5 hours. So he's a candidate for thrombolysis, and also he's a candidate for thrombectomy. So guideline says you thrombolize the patient, bridging thrombolysis, and don't waste time, immediately shift the patient. Don't wait for document that artery is open or not. Don't wait, directly shift the patient. So anyway, most of the patient we do thrombectomy, most of the patient receive thrombolysis. Here only not putting a sheath, that is the problem, while removing the sheath the problem. So we keep sheath, femoral sheath, which is normally 8 French or 9 French, we keep there for 24 hours, and next 24 hours Once thrombolysis, that effect is gone, then we remove the sheath. That is the change we do. But thrombolysis is not a contraindication thrombectomy, and thrombolysis has to be given. A patient is having a window period for thrombolysis, you should not deny thrombolysis.
So my last question to Dr. Parikh, sir. There are some set of patients who like to wait it out at home with stroke symptoms, imagining that it will recover, and very small percentage actually do recover. They had a left-sided weakness, upper and lower limb, facial asymmetry, and within 24 hours, it normalized. How do you approach such patients? How aggressive is your workup, and what medications do you suggest?
Well, these are lucky patients to come out, first of all. But at the back of your mind, you should always keep there is something hidden thing which is challenging to you. Well, if these patients, normally if they have, when we have done these imaging studies and we have ruled out bleeding and other thing, the focus is emphasis upon the mainstay of the antiplatelets and anticoagulants. Apart from that thing, investigative aspect would also include cardiological investigations to rule out associated atrial fibrillations and otherwise. As I said, MR angiography would also be useful because the patient has survived 24 hours. Yes. We do not know after 24 hours he may throw bigger things. In fact, the nature is giving you a good warning signal. Yes. So you should not ignore such signals. Taking full care that patient doesn't have major occlusions downline from which one embolus has just gone ahead in that line, and that embolus has fizzled out and the patient is normal. That does not mean that patient is normal to send home. We have to become a little bit more aggressive in a patient because you have enough of time in your life to find out whether he is harboring some lesions like a transient atrial fibrillations, or if he has got carotid block, and from which from the atheroma the small embolus has gone. So these patients have to be investigated before you send them home, and they have to go back on the antiplatelets or anticoagulant depending upon the underlying conditions.
So you would still re-stratify them and make sure that they don't land up with a repeat.
We have to have the dyslipidemia, diabetes, hypertension has to be cured, and lifestyle changes has to be cured.
Sure. So that's it from our side for the paralysis session. I thank all the faculties. Can I request Dr. Alka Patnaik ma'am to please come up on the stage to felicitate the faculties? We started off with Dr. Shekhar Patil. Then Dr. Vishal Chafle. Then Dr. Kaushik Kulkarni. And last but not the least, the most vastly experienced, Shailik Parikh sir. Let's just take a group photo, all of us. So moving on to the next session, polytrauma. So as most of us working as family physicians, general practitioners, this is not something which you expect to land up at your place. Yes? No? Accident has happened and someone is landing at your clinic, less likely. But you will definitely get a call what needs to be done. So we still need to know what are the emergencies that cannot wait and watch. They need to be fast tracked. And we have a elite team for helping us and guide us in doing that. So let's welcome the faculties on the stage. Dr. Siddharth Yadav, Senior Consultant, Orthopedics and Trauma, Apollo Hospital. Dr. Sameer Chaudhary, again Senior Consultant, Orthopedics and Trauma, Apollo Hospitals. Dr. Nitish Arora, Senior Consultant, Orthopedics and Trauma, Apollo Hospitals. And Dr. Sharif Dudekula, Senior Consultant, Orthopedics and Trauma. So for ease of discussion, I know trauma can manifest in different ways. We are sticking to the orthopedic part for today. Hopefully with the next session, we try to cover the remaining one. The one which has always puzzled me is the pelvic injury. So I'll start off with Dr. Siddharth. You have a 52-year-old male after a bike accident. So what actually do you feel with predict the severity of injury?
Yeah, it's very important in history to ask patient how the accident has happened, whether he has just fall down at home or some high speed or high velocity injury. So definitely looking at this picture, asking them if he fell down while speeding bike, the severity of injury is suspected high.
So my next question is to Dr. Nitish. So someone informs you the vitals are normal post an accident like this. So does that rule out injury?
Definitely not. So considering the mechanism of injury, even normal vitals at this with this sort of injury doesn't rules out the significant injury, because there are grades of shock. With this accident, I consider to be it as a very significant injury in terms of internal bleeding. Injury can be to thorax, abdomen or pelvis, and there could be internal bleeding. Even with normal vitals in stage 1 shock, this doesn't rule out significant injury.
So we still keep a watch on them,
yes,
and not
absolutely.
take it off as normal.
Absolutely.
Sure. So my next question is to Dr. Sameer. So what is the biggest worry with pelvic injury? Why should we all be so much fussy or educate ourselves with pelvic injuries?
So as we've known, pelvis basically is the place for your vital organs there, the reproductive organs and the major blood vessels. Blood loss is the main problem. So any pelvis injury, we anticipate a 2 to 3 liters of blood loss.
Okay.
So depending on the type of pelvis injury, we anticipate how much is the blood loss, and our biggest worry is that loss to basically mitigate measures to prevent the hypovolemic shock.
Okay. So the next challenge comes is how do we diagnose it? So my question to Dr. Sharif, should I keep a watch by rocking and squeezing the pelvis to see if there is any injury time and again?
Keep rocking and squeezing the pelvis is not absolutely not indicated, because according to ATLSC protocol, you can do pelvic compression test, you can do once.
Correct.
By repeatedly doing rocking and squeezing to diagnosing pelvic injury, it leads to dislodgement of blood clots, leads to severe blood loss. It may be associated with severe abdominal injuries, associated pelvic organic injuries. It leads to severe blood loss and patient can go into unstable status. I don't recommend repeated rocking and squeezing.
So like you said, it's to be done only once, the pelvic compression test. So preferably, who would you prefer doing this test at least once? Should a family doctor do it, a post-MBBS, a trauma surgeon, an emergency physician, a critical care? How would you prefer?
Emergency physician is the very best one to do that test. Yes.
So at least once we should do it and not keep repeating. Sure. So my next challenge, the question is to Dr. Siddharth. Does pelvic binder really help? And let's say I don't have a typical formal pelvic binder. Is there any makeshift arrangements that can be done?
Yeah. We have to see whether, first is, as we have discussed, whether it's a high velocity injury. So we suspect unstable pelvic injury. And we must, when patient comes, we must put our hand in both sides of the iliac crest and try to gently see
Squeeze
whether
it.
it is moving and whether his legs are externally rotated. And after that, this binder is very important. Binder we should apply over the hips, over the greater trochanter, not over the iliac crest. And if you don't have binder, then you can do like a bed sheet, make it around 1.5 feet, and then 2 people can tie it. But binder really helps. It compresses the pelvis, and that reduces the volume, also the blood loss. So it is good to have binder.
And so once you apply it properly, when do you prefer it should be opened strictly? Like people will open it for a Foley's insertion, multiple people would want to examine. Is that okay, or it should finally be opened only in the OT when you're actually intervening?
No, for putting Foley's or you can open it, but it is not, it is a relatively compression. It is not absolutely, we are assuming we are closing the pelvis.
Correct.
So it will be just to make it stable. But it's not absolute like putting a tourniquet kind of thing. You can open gently and avoid too much moving of pelvis or legs or shifting patient again and again.
So my next challenge is to Dr. Nitish sir. Any role of tranexamic acid? We have all heard the moment there is bleeding from anywhere, just give Tranexa. So is there any role, and what dose usually you prefer?
So I think pelvis fracture per se, any abdominal injuries, the major cause of the mortality is the internal bleeding. And in 2010, there was a CRASH 2 trial that highlighted the importance of tranexamic acid in case of polytrauma patients. So that trial showed that tranexamic, this Xarelto or tranexamic acid in first 1 hour, if given, that reduces the mortality in a polytrauma patient significantly. First 1 hour is of critical importance, but even if it is delayed, you can give up to 3 hours. So the dedicated timing is, if the patient comes to you within 3 hours, give tranexamic acid. First in a loading dose of 1 gram over a period of 10 to 15 minutes. Then 1 gram in next 8 hours in a infusion mode. But then that trial also highlighted that do not give it after 3 hours. Why? Because that increases the mortality if you give it after 3 hours. So if the patient comes to you within 3 hours, give the dose immediately. If the patient comes to you after 3 hours, do not give it. So that was the highlighted point in that study, and that we have been following since many years. I think 15 years have passed.
Just to be given over, so it is a hybrid.
Yes,
Yes.
so it's a. So tablet is there. I don't think so.
So
is
tablet
there
usually doesn't come under recommendation for polytrauma patients to be given. You will always prefer giving
IV.
injectables.
So in trauma patient, IV is always the preferable choice in a recommended dosage that we have.
So in
just
fact,
discussed.
if we go one step ahead, I think CRASH 3, what they recently released was, if your dosage of 1 gram is gone and you're not able to start with the remaining dose over 8 hours because you are going to transport somewhere else, you give first dose of 2 grams. So that is how they are trying to slightly make sure that the bleeding is kept in check.
But I would like to add, it is not a alternative to
Correct.
the fluid replacement
Correct.
therapy, shock
Absolutely.
management.
This is just helping
Okay,
to-
so initially as you do emergency, you replace the fluid,
Yes.
do the blood transfusion. And secondly, this tranexamic acid should be given slowly infusion.
Yes.
He is saying infusion.
Yeah.
If you give bolus, it can cause hypotension.
Yes. Hypotension.
So it is not advisable to use in anywhere. In a hospital setup, you can do it.
Yes.
So I'll add few things just in brief, as highlighted by sir. Bleeding is of major concern in polytrauma. First and foremost is pelvic binder is very important. Fluid replacement and blood replacement is also very important. And then the next is the medical part, which is the tranexamic acid. And transfer to a higher specialty or a referral center who is capable of dealing these sorts of pelvic injuries is also an important part of this polytrauma management. Thank you.
So that's my next question to Dr. Sameer. Fluids or blood, how do you decide?
With pelvis injuries, always blood first, because the challenge with fluids is they dilute the coagulating factors. So always prefer blood, and generally there is a combination which is recommended. We use a PRBC plus platelets,
So
etc.
that is what we follow as massive transfusion protocol, where the ratio is 1:1, PRBC, FFP and cryo.
So if it's not available, we start fluids, but whenever possible and whenever we are expecting a hypovolemic shock, blood is the first choice. About going back to the binder part, now there are one or two situations where binders are not recommended. If your imaging is already done and you have a lateral compression type of pelvis injury,
So then-
binders are actually not recommended. Or if you have a neck femur fracture, we don't want to disturb it.
Yeah.
So there you don't put a binder, otherwise you are actually increasing the problem for the proper treatment. protocol.
For clinic setup, like many of our
Yes.
colleagues are in industrial trauma, so then they should start a massive IV fluid,
Yes.
at least 100-150 ml
Yes.
per hour while shifting or transporting the patient.
Sure.
So blood transfusion can be taken care as you
Sure.
do in ER. You have a
We can
negative
keep
blood
things
group,
ready.
and you do without that.
Sure.
But fluid therapy is important.
Sure. Now, next question is to Dr. Sharif. Let's say we have whatever we have known right now, we have followed it, and the patient seems to be pain-free, vitally stable. Should we still transfer, or should we just wait and watch?
We should transfer the patient, sir. If patient is unstable at the local center, just give some IV fluids and stabilize the patient. Once stabilize the patient, as early as possible, you should shift the patient to higher center for better management. If patient is stable in the local center, just you can apply some pelvic binder, do some images, then transfer the patient. The pelvic injury polytrauma patient can deteriorate any time because of high grade of some internal injuries. So it is always better to transfer the patient to higher center, especially with pelvic injuries.
So like we discussed in STEMIs and stroke, the golden period, that would still apply for trauma patients also. So the earlier they receive stabilization and definitive intervention, it's going to help them recover quickly. The last question for the pelvic injury series to Dr. Siddharth. I've shown some types of pelvic fractures. Where are you comfortable waiting and watching, and where do you feel you aggressively need to intervene, and what intervention would you prefer doing? In brief, if you could tell us.
So if you see the lowest one, the first, we have to see in further classification is stable or unstable.
Yeah.
So top one is mostly they are unstable, top two,
Correct.
and the lower one is partially. Therefore, one more classification for stable is when you have only this anterior part. Suppose only pubis rami fracture,
Yes.
or the SI joint, that is stable. These are all relatively can be unstable. So we have to stabilize them and then plan for fixation.
And your approach to stabilize them would be to...
First, most of these pelvic injury, they are high velocity injury. Most of the time they have urinary bladder injury or some other organ injury. So with that, we have to rule out any visceral injury for doing CT scan.
Okay.
And accordingly we decide.
Okay.
It's not only isolated bone injury. So most of the time when we treat, urologist is also involved, the GI surgeon is also involved. And if there is any, suppose, bladder injury, then we do same time they repair bladder or urethra and we fix the pelvis.
Sure.
So as soon as patient is stable, we try to fix it. Emergency fixation is like damage control orthopedics. We put external fixator. That is as early as possible. And then once patient is stabilized, we can do internal fixation.
Okay, sure. So that is for the pelvic injuries. We move on to upper limb injuries. So my next question is to Dr. Nitish. Say you have a 28-year-old male who's come to you after a road traffic accident. So which upper limb injuries you feel they look minor but they are actually very dangerous? And can you brief us the importance of the views that we do in general X-rays? Because I've sometimes seen that there's a unilateral view done and the patient has been transferred. Or whether it's someone who's recently joined into training, going for a single view. So what is your take on minor but dangerous injuries?
So anyways, so I'll start with the generalized discussion. So which upper limb injuries looks minor but are dangerous? This is obviously dangerous. No one will deny that. But then starting with the, so 28 years old is okay, but then starting with the childhood, a young boy with 7 years, 8-year-old with the elbow injury, that is dangerous. Do not ignore it. Even a minor looking supracondylar fracture or a lateral condyle fracture is very notorious. Supracondylar fractures, distal humerus fractures in a childhood, it is associated with compartment syndrome, neurovascular injuries, they are very notorious, believe me. A child who has fallen today, if it comes to you tomorrow, he might be normal today, but he might have a swollen hand tomorrow. Do not ignore it, get the x-rays done, get the proper treatment with a consulted proper orthopedic surgeon is done. Then lateral condyle fracture. They might not be associated with compartment syndrome, but they are associated with non-unions. But then non-union are always notorious. They have a long-term functional impact. So a child with an elbow injury is a thing which is to be looked up, not underlooked upon. Then other are Monteggia fractures. They can have a elbow radial head dislocation. So those things are also very important. So childhood elbow injuries are very important. And one more thing I want to highlight the importance is that he asked for orthogonal views. Do you have the x-rays? Yeah. So just look at the right side x-rays. So AP view looks okay. So child with a wrist injury, we got the x-rays done, simple AP view looks okay. But then this view, this slide highlights the importance of getting two views. So always take two views, AP view and lateral view, just to confirm that you are not missing anything. AP view looks okay, but then the lateral view, if you miss it, the child will have wrist deformity or he will have impaired function of the wrist. So always get two views of an X-ray whenever you are suspecting. The other things, as the question was asked, that compartment syndrome in upper limb is very common. Even in adult, 28 years old, compartment syndrome is very common. Open fractures or impending open fractures, they are very notorious. Open fractures has to be dealt like a emergency. Antibiotics within 1 hour, debridement within 6 hours, this is the rule. Then impending open fractures. Impending open fracture means fractures which are not open. The wound is not there at present, but the bony piece is protruding out of the skin. It is trying to protrude out of the skin. If you don't treat it immediately, if you do not reduce it immediately, it will become an open fracture. So that is also very important. Then last is neurovascular injuries. So all neurovascular injuries are an emergency thing. The other upper limb fracture I would like to highlight is the scaphoid fracture. So scaphoid fractures, minor wrist pain. After a fall, they will come to you in an ER. You will get the x-rays done, but you will miss the scaphoid fracture. So for scaphoid fracture, to diagnose scaphoid fractures, you need to have a very high suspicion. Always look for the tenderness in the anatomical snuff box. Get the spatial scaphoid views done. Even if you still have a doubt, you're not able to confirm it, get the CT scan done. Because if scaphoid fractures are not treated appropriately in an acute setting, they will have a long-term consequences. Even they are small bones, but then for a musician, for a carpenter, for a chef, this wrist function is very important and they can have a long-lasting impact. Thank you.
So if, let's say if I have to simplify it, Dr. Samir, a rapid fire, what decides your urgency? Is it pain, is it deformity, or is it function? What should be checked first and is of prime importance?
So I think we're missing neurovascular here.
Yeah.
I think neurovascular is the first thing which will decide. Pain, pain is a very tricky thing. Means a minor issue can present with a very high presentation of very high pain. And again, followed by neurovascular would be deformity and third would be pain.
So that is how you would want to prioritize where you need to fast track things.
So for a clinical setup, if you want to convey, like in clinic when patient comes to our clinic, so mostly we miss posterior shoulder dislocation. Anterior shoulder dislocation is very obvious,
yes.
But posterior sometime we miss. Or sometime also we miss posteromedial elbow dislocation.
Yes.
So if any, and also scaphoid. Scaphoid is missed by most of the many time orthopedic surgeon also. Without scaphoid view, you cannot see the scaphoid fracture. So three things are important in clinic. Number one. Number two, when always take two views. And number 3, if any restriction of movement, then you should anticipate or expect something more.
Yeah.
Whenever there is a fracture, there is not only fracture, there could be other injuries also,
Yes.
soft tissue injury also, vascular injury also. So, but just seeing X-ray is not suffice. We should clinically what are the other associated injury. So and then as soon as possible, we should send to the specialist, and we should avoid any massage or local therapy. That is for the clinical setup, for clinic practice.
So I think many times the point has been touched based on, but Dr. Sharif, 2 or 3 injuries, no wait and watch has to be referred. What would be those?
Please, sir.
Urgent referral is needed. There is no wait and watch.
Already Dr. Nitish, Dr. Samir sir told that if patient has not only upper limb, in lower limb also, if patient has any neurovascular deficit, it should be referred as early as possible. Because of golden period is only 6 hours, we can save the limb if you refer patient very early. Second, if any dislocations in any joint dislocations like shoulder dislocation, elbow dislocation, if you refer very early, we can reduce very easy. If you delay to refer the patient, it is very difficult to reduce the fracture also. Sometimes it may need open detection. And third thing, if the fracture is associated with compartment syndrome, like forearm and hand, both bone legs, I mean lower leg and foot. And if there is any crush injuries or any open fractures like from simple grade 1 injury to grade 3C injuries. I mean, simple puncture wound is also become very dangerous. Sometimes it leads to some infection. So it's need urgent debridement, wash and fixation. Maybe with we can fix with this simple external fixators at early stages. Later on, once the wound is fine, then we will go for definitive fixations. Thank you.
So to add, I think for all the non-orthopedic, certain things which are very important is splinting and support. If a patient comes to you and some elbow injury, at least put an elbow pouch for shoulder injury, and then refer for X-ray or specialist.
Correct.
Orthopedic part, it is difficult to treat, get in a clinic or non-orthopedic.
True.
Yeah, and splinting is very important. If you go for 100 years back or in any village, they put some chata, bans or bamboo, anything. They support the fracture, because if you don't immobilize the fracture, don't support, then it keeps on injuring the surrounding tissue. So I would say in any clinic we should have at least elbow pouch, some cocker splint, femur wire splint, some knee braces, long knee brace. So elbow, some fracture is there in the tibia, you can put a long knee brace. There's easily available elbow, this cocker splint, finger splint. So those you can apply, and then better to shift and as early as possible.
Sure.
Yeah.
So I will add a last point. So there are, whenever I meet people, they always ask, sir, whether we should reduce the fracture in a clinic or whether we should send directly. So I will just say, whenever there is a fracture comes to you, just palpate the pulses. So if there is a fracture here, palpate the distal pulse. Yeah? If there is a dislocation in the elbow, just palpate the distal pulse. If you can reduce it, well and good. If you even cannot reduce it, we all know the anatomical position. So whenever we all know the anatomical position means the hand is straight. So if there is a crooked hand, just make it little straight, and as sir told, bind a Kramer wire or a crepe bandage. If there is a crooked leg, make it little straight and either tie a plaster or a Kramer wire splint. So reduce it in a normal position. Do not try to anatomically reduce it, but reduce it in a normal position so that the pressure on the neurovascular status bundles is reduced and it will unlikely to cause any further damage.
So my next question is to Dr. Siddharth. Say you have a patient come in with shoulder dislocation. So what is your approach for such patients?
So as I earlier mentioned, anterior shoulder dislocation is very obvious. The posterior sometime we miss. So anyway, it should be sent to a center where we can give anesthesia or sedation. Once you give they get pain relief and muscle, they are relaxed. It's very easy to reduce. But just pulling them without anesthesia, without sedation, then you may end up in fracturing.
Correct.
Proximal humerus. So I think this should be done in a hospital setup. And first thing is doing imaging, and then as soon as possible, like we have like in our ER, you give
procedural sedation.
There's a procedure room, you can give anesthesia at all in any bed, you have monitor there. So most of the time we reduce in ER. We never took, I don't remember in 10 years,
we haven't
took any
shifted
patient
to
OT. We, within a few minutes we are reducing it and then immobilize it. And after that we do MRI for further, but immediate care is as soon as possible reduction.
Sure. So the next question is to Dr. Nitish. Clavicle fracture, how do you approach?
Clavicle fractures, I think it is one of the very common fractures. How do you approach? So yes, first and foremost, for each and every fractures, you need to rule out whether it's an open fracture or an impending open fractures, or if it is associated with any neurovascular injuries. Clavicle fractures, they are sometimes associated with brachial plexus injuries, so you need to rule out any associated neurovascular injuries or brachial plexus injuries if they are associated with clavicle fractures. Then you need to see whether it's an open fracture or an impending open fractures. As I told that, sometimes a fracture ends, they are just under the skin. They are not open at present, they are under the skin, but then they are trying to pierce through the skin. So clavicle fractures, they are very common in these fractures. We have a very common scenario that they are just under the skin and they are impending open fractures. So we need to see these two things. Regarding these, once we get the X-rays done, regarding the management of these fractures, majority of the clavicle fractures, they can be treated very well conservatively without surgeries. Most of those patients, they do very well whether the fracture unites or it doesn't unite or malunites. The relative indications of the surgery or to refer the patients are if it is associated with neurovascular injuries or if it is an impending fracture or the patient wants a early functional outcome. If he is a sports person, he wants to go to sports early. If he is a manual laborer who wants to go to his work early, or if the fracture is too much displaced that it is overlapped by more than 2 to 3 centimeter, or if it is angulating too much that is impending the skin. So these are the only indications of clavicle fractures who need surgery. Otherwise, majority of the clavicle fractures in young age, in the middle age group, or even in the elderly age group, they can be treated conservatively with good functional outcomes. Not good radiological outcome, with good functional outcomes.
So just to add on what Nitish said, historically, I'm seeing for last 30 years, so around 20 years back, there was always in dictum, okay, never to operate clavicle. Okay, it should be managed conservatively. But we have seen a lot of malunion or pseudo-union. People, they are painless, but some movement and weakness and pain on exertion. So nowadays, it is changed for last 2 decades. The indication for clavicles, they are increased. Number one is the lateral end of clavicle, that is very disabling, that requires surgery. Number two, if clavicle is fractured and overlapped more than 2 centimeter, then it gives mechanical weakness, also disability. And most of the time non-union, that also require fixation. And number three, as Nitish said, it's penetrating or a compound or associated with vascular injury. So clavicle fracture we have seen for last 2 decades, there's more indication for surgeries. Earlier there was a rule, just to sum up.
About approaching him in the clinics. So a simple sling is more than enough. So even if you don't have a sling, a scarf used to make a sling is more than enough to immobilize. First thing is to check the pulse and the neurology.
So my next question is to Dr. Sameer. So a lot of time kids come to us casually playing with their siblings or parents. The elbow gets pulled. Is it safe enough to manipulate without X-ray?
So
and what should we do? Pronation, supination? It's always confusing.
Pulled elbows and supracondylar humerus, they would overlap in presentations. This is, age group is more important when you're attending to the patient. This is generally a 1 to 4 or 1 to 5 age group. History is very important. Pulled elbows are notorious to recur. So the siblings would also have it, because if there is a generalized hyperlaxity in the family. So if you've had the history of pulled elbow, these are clinical diagnosis, because imaging will not diagnose, the standard X-ray will not diagnose it. Either you need a sonography or an MRI, which is an overkill for this. So pulled elbow is always a clinical diagnosis. We check on the pulse, we check on the neurology, just simple this okay sign to check all three nerves. And manipulation is in pulled elbow is not to an extent to cause neurovascular damage. So generally there are two maneuvers, either you pronate fully or supinate and hyperflex. So I follow supination, hyperflexion, that has worked. Many a times parents have learned the techniques, they have reduced at home and then they show up. Kids also, on the way also, if they're just put in a sling, sometimes they get reduced. Because it's generally a subluxation more than a dislocation.
Correct.
So I think it's very much safe if you have a proper history and then go ahead with it.
I would like to add one point, whether we should get the X-rays done or not. So history is very important. So there are two modes of history which you usually get. First is a mother or a caretaker is playing with a child on a bed and he was just holding, giving his finger to hold it to the child. And then he pulled it up and then there was a sound and the child was not able to move his hand. In that scenario, it's a classical sign of a pulled elbow. You don't need to get the X-rays done. The other common history is while doing gymnastics, they were hanging onto a bar and then they fell down. Okay, and then they landed onto elbow. So this is a scenario in which both the things can happen. They were hanging onto a bar and the pulled elbow happened and then fell down, or they fell down and sustained an injury to the elbow. In that scenario, you should get an X-rays done to rule out a fracture. So if there is a fracture, treat the fracture. If there is no fracture, then the pulled elbow is a likely diagnosis and then treat it.
So my next question is to Dr. Sharif, and we have tried to touch base, but let's say you have a patient with FUSH, fall on outstretched hand. It's a Colles fracture, what you feel. Should you reduce splint and then transfer, or just splint and transfer?
Sir, Colles fractures are most commonly in elderly people who is very osteoporotic. That is classical indication of osteoporosis. If you are trained enough to reduce the fracture, you can reduce. Otherwise, as Dr. Nitish told, just straighten the hand and splint and refer the patient. If you can't reduce or you are not trained enough to reduce the fracture, then just splint it and refer the patient to higher center to our better orthopedician. That's it.
So my next question is to Dr. Siddharth. We mentioned about scaphoid fractures. So you mentioned about extra X-rays that need to be done. So what view do you prefer? And is MRI mandatory always or no?
Standard all the technician knows is scaphoid view. Okay. This is called scaphoid view, oblique view, and this is must. If you have, is most commonly missed is scaphoid fracture, even by orthopedic surgeon. If you do standard AP in lateral view. So if you have a tenderness on the base of the thumb, anatomical snuff box, always do scaphoid view, and these require a prolonged casting up to sometime 2 months or so, Okay. So scaphoid view, you can easily do it.
My next question is to Dr. Nitish. This is something that we always fear. Not this, the question, the compartment syndrome. So what exactly is compartment syndrome and when should I just raise the alarm?
Okay. So compartment syndrome, I'll tell you, it's a very, it's an emergency. There is no wait and watch in compartment syndrome. So first and foremost, we need to have a very high suspicion to develop, raise a diagnosis of compartment syndrome, because there is no investigation per se that we routinely use it to diagnose a compartment syndrome, because it's a clinical diagnosis. So first and foremost, we need to know the common fractures that are associated with compartment syndrome, like distal humerus fractures in a child, forearm fractures, and proximal tibia fractures, fractures around the knee. So these are very common fractures which are known to cause compartment syndrome. So compartment syndrome is a clinical diagnosis. So we all know 5 signs: pallor, pulselessness, paresthesia, and so all these 5 signs we all know. But then all these signs are not able to diagnose compartment syndrome. So for compartment syndrome, you need to have a very high suspicion in terms of you need to have a very huge swelling, which is tense, which is causing pain out of proportion. So you feel that tibia fracture hai, but then why is shouting in pain? So you, and limb is swollen, it is red. So you suspect a compartment syndrome. So swelling, pain out of proportion, and important sign is paresthesia. So first sign is paresthesia. If the patient is complaining of tingling in the lower leg, sir, झुंझुनी वाटते मला पायाला. It is a sure shot compartment syndrome. Do not wait for the pulse to disappear. If you are waiting for the pulse to disappear to diagnose a compartment syndrome, we are very late. So we need to have a high suspicion in terms of a swelling, pain out of proportion with paresthesia. So these are very important signs for diagnosing a compartment syndrome. So for example, the other scenario is the patient is in coma. He is intubated, he had a head injury. Then how do you diagnose a compartment syndrome? So there's only one thing, that is a clinical judgment or experience. If the limb is swollen, tense, and you feel that the fracture is that sort of that will cause a compartment syndrome, do a fasciotomy. In compartment syndrome, better to do a fasciotomy than to rather avoid it. Then treat the fasciotomy with other methods. How do you treat it? Like vac lagao, then do a secondary skin grafting or a secondary closure. But then in compartment syndrome, it is always better to suspect than to rather just wait and watch.
So last question for upper limb injuries, but I think this will apply to every one of us, for Dr. Sameer. I think the most common court calls will be for traumas at different levels. So who saw the patient first, who gave the definitive treatment. So we both are party to going to the court. So what have you realized over a period of so many years of your experience? Where do we fall flat?
So at least Apollo has got a very good trend of documenting. So just now Dr. Nitin was telling me he had a court case in 2017 when we started. He found a paper where we had written notes for one of the crush
That's
injury.
the worst part, because 2017 calls are coming right now. I don't remember what patient, what is the injury, what. Unless I have not documented, I don't remember a damn thing.
So no doubt, but documenting comes first always. And commonest challenges, it's difficult in kids to document neurology.
Okay.
One, very common, especially supracondylar humerus fractures. So about the pulse and the neurological status. Those situations are absolutely panic driven, not because of the kid, but the parents and the attendants. And we have this dedicated area where there's absolutely common scene, one parent sitting with the kid in the lap and the other parent is hovering around and 2-3 relatives. And in that, to calm them down, to talk to the kid, kids can be calm if everyone else is calm, and then to check a neurology, simple neurology, can be very easily missed. So that is very important, and documenting pre-operatively all the more important, because supracondylar humerus, especially in kids, are situations where we lose the pulse or we have neuropraxis after the surgeries also. And when it comes to kids, parents are overprotective and they become very suspicious of the situation. So to take them through the counseling, documenting whatever has been counseled, anticipating what steps you are going to do, both situation post-op, whether it is vascular, neurology, whatever happens, and taking proper consents for them are very important. So same thing, as you said, what happened in 2017, we won't remember.
Even I would add, even for if patient is coming for clinic, anyone's clinic or physician clinic, and there also they should mention it. So we should mention, we have seen the patient, swelling is there, radial pulse is present, and we are referring patient to hospital. And then sign and properly. Other thing is, when we have here teaching department, lot of DNB, this year also 22 have joined, and all of them we tell to make a stamp and their name and registration number.
Yes.
Because you are not able to find who has written.
True.
And any document, if it is not signed and stamped without registration number, it is not stand in court of law. So these things are, documentation is important. Even if what we discuss with the relative, that also normally we write, and I write and file. I told relative, you want to go somewhere, he told his, even if a relative's doctor is calling, a relative's doctor so-and-so called me and he advised this much and I discussed, that also we should mention. That is also important in if anything happens. Sure. Thank you.
So the relevance for this question was the code call always comes for the first person who saw the patient and obviously the definitive treatment. So don't feel that because I'm not an orthopedician, I will never be called. They can always call you that when you saw the patient, what was the scenario? By the time you referred, obviously the specialist will obviously putting their things on the
Even
paper.
for insurance patient also, when
Yes.
they are coming to your visit, your clinic for say around knee ligament injury and you advise MRI, then the insurance also they ask for the first consultation. So documentation at clinic is very
Yes.
important.
So moving on to lower limb injuries, my question to Dr. Sharif. Which lower limb injuries are most commonly missed? And I think they are really the most commonly missed injuries. People have their little accidents and come after a week with problems.
Some most common lower limb injuries, especially in elderly patients, the neck of femur fracture. We have seen so many cases like that. Patient had a fall, having pain in hip, and went to local doctor and got X-ray. That is undisplaced. After 3 days, patient came to our OPD with severe pain. Then we repeat the X-ray. There is a displaced neck of femur fracture. This is most commonly missed injury. If you are suspecting any hip pain in elderly patient, just ask them to do SLR. If patient able to do straight leg rising, obvious maximum there is no fracture. And patient cannot able to do, that means there is something. Yeah. If X-ray is also normal, then go for CT, some higher investigation to diagnose the fracture if there is. According to that, then we will treat. Second one, at the knee, there is a lateral knee dislocations, mainly patellar dislocation. Because patellar dislocations most commonly reduce spontaneously while shifting the patient to the emergency. This is the most common injury, most common dislocation which we missed in patellar dislocation, which we missed in the emergencies. Third one is any compartment syndromes in the lower limb. I mean, especially maximum doctors, that local doctors are not trained enough to diagnose the compartment syndrome. This is the most common thing. If you are suspecting any compartment syndrome, as early as possible, you can refer the patient. Otherwise, the patient will lose the limb. And fourth one is Lisfranc injury. I mean, midfoot injuries. This is very notorious fracture and very important fracture to address. Because once you ignore the Lisfranc injury on any midfoot pain, it will lead to chronic problem. Patient can't able to stand, patient can't able to walking on the future, patient has pain in future. So it is, they get the CT scan and diagnose properly the Lisfranc and treat accordingly. Lisfranc needs always surgery.
On for the, because many elderly patient, geriatric patient, and
yes.
they call physician for a house call. And now we are doing X-rays also at home.
Yes.
Portable X-rays.
Yes.
So whenever you suspect any pain in hip, elderly, and although they can lift their leg, that's an incomplete fracture, and that can be managed with minimal intervention like percutaneous screw or bed rest. But if that same fracture gets displaced, that require a major surgery like partial hip replacement kind of thing. So whenever you suspect something, always tell them not to make patient walk, use walker and do CT scan. This is this thing for those who are doing home visit, and when many times the elderly patient, they are calling home and doing X-ray at home. Thank you.
To add to sir's thing, we often get calls from general practitioners that my patient has fallen down and we have a portable X-ray facility, what X-rays to take. So especially when these are bedridden patients who are not able to walk out. So as he said, a simple asking them to lift the leg straight up. If they're not able to, always suspect a hip fracture, which is commonest is neck femur fracture. And first X-ray should be the pelvis and the second should be the spine. Because again, when these portable X-ray people come, they only have 2 cassettes. And they would shoot, go back, and so I have had 3 or 4 incidents where the practitioner is calling, where they're getting the X-rays, but only pelvis was screened, spine was not. So at least these basic commonest fractures we come across are lumbar spine, and dorsal-lumbar spine and pelvis. So a simple PBH, AP and a lumbar spine lateral helps.
Sure. So I think the next question which I was going to ask Dr. Siddharth, he already answered. It's a myth. If you're able to walk, that rules out fracture. I think we agree.
Yeah, already I told, whenever there's a fall and pain is there, first thing is to X-ray and then get it further checked. In elderly, they're osteoporotic. Even a partial incomplete fracture will get complete, and that require a major surgery.
Yep. So next question to Dr. Nitish. Which injuries must be referred immediately? There is no wait and watch. What we did for upper limb, similarly for lower limb. This has to refer, there is no wait and watch.
Okay. So starting from hip, young patient, hip fracture is an emergency. Neck femur fracture is an emergency. It has to be treated as early as possible. It has been shown that fix the hip fractures within 24 hours or maximum 48 hours, yes, 72 hours. In India, pizza delivery occurs faster than fixing these fractures. But then hip fracture is an emergency in a young. It should be fixed as early as possible. Neck femur fractures, because they are prone for avian and non-unions, and they can have a long-term functional consequences in the future. IT fractures in elderly is an emergency. So it has been shown that intertrochanteric fractures, if fixed within 72 hours, reduces the mortality rate significantly. Although they have a higher mortality rate, it has been shown that 30% of the elderly patients with hip fractures, they die within 1 year of their fractures. So it is as equivalent as to a heart attack. And there was one more study which has shown that a female having a breast cancer and a male having a IT fracture, the risk of dying from both the diseases in 1 year is same. So IT fracture is an emergency. It should be fixed as early as possible. As we have been pointing out since last few minutes, that at least get the X-rays done. If an elderly gentleman has fallen down in a bathroom and he is unable to come up to a bed, or even if he is able to come up to a bed with great difficulty, he has pain, at least get the PBH-AP in internal rotation X-rays done and a spine X-rays done to rule out hip fractures. Because most of the time what happens is, sir, fracture गिरे थे बाबा जी बाथरूम में, लेकिन उठ के चल के आ गए या उठ के चल के नहीं आया, हमें लगा कुछ नहीं होगा, धीरे धीरे हल्का सा गिरे थे, फिर 7 दिन बाद पता लगता है कि पैर swollen हो गया है. They have developed complications of these fractures. They are not able to walk. When we get the X-rays done, 7 days हो चुके होते हैं, and then they come up to us. IT fractures है. So it is already too late, because complications of bedridden status, DVT, bed sores, they starts to develop as early as 24 hours, 48 hours. So the second most common is IT fractures, which should be referred immediately. The third is shaft femur. Shaft femur fracture is again an emergency in terms of blood loss. 1.5 liter almost blood loss happens immediately. Then proximal tibia, distal femur fractures. Proximal tibia fractures, they are known for compartment syndrome, vascular injuries. They should be referred immediately. Distal femur fractures, they are relatively okay. They are ठीक है, plaster लगाओ आराम से 1-1.5 घंटा पेन किलर्स देके भेजो. लेकिन other fractures, they should be taken, referred immediately. Then dislocations. Dislocations are very important. They should be either reduced immediately by the treating physician, or they should be referred to an orthopedic surgeon who is able to reduce these dislocations. Then ankle fractures. Ankle fractures are relatively, I'll say, they are not emergency fractures if they are not associated with dislocations or syndesmotic injuries. So ankle fractures, you can splint them, you can send them to the treating doctor. Next day, send them home with rest, ice pack applications, limb elevation, painkillers, and send them home tomorrow. Send them to the hospital tomorrow. And the last is the compartment syndrome. So compartment syndrome, as we have already discussed, that it's a fracture which needs urgent treatment, or it's an injury which needs urgent treatment. And to diagnose compartment syndrome, we all as a physician needs to be aware of all the features that might raise you a suspicion of a compartment syndrome.
So next question to Dr. Samir. We discussed that IT fracture needs to be treated, like Dr. Nitish also said, within 72 hours. Managing pain in this patients is really pain in the censored word. But how do we deal with the pain in this? And obviously surgical part you will be taking over, but how do you control the pain?
The commonest situations are they fall in the bathrooms. Commonest, the senior citizens falling in the bathroom, somehow they manage to get in the bed and then the cascade starts. So they're not able to visit the washroom, and then we have calls from relatives or the practitioners, this is the situation. Biggest challenge is transporting them.
Yes.
Majority of Mumbai houses wouldn't have lifts. So the best possible thing is to call an ambulance. Always call an ambulance at the earliest suspicion of a fracture. because immobilizing a hip fracture is next to impossible. Means giving traction and holding the limb practically impossible. A simple solution, you can call for a long knee brace, put the brace, so that reduces some movements indirectly, not directly. But when they are in the hospital, traction is the first thing, or the Thomas splits. But in practical situation, when they are home and they are about to reach hospitals, best is to call the ambulance at the earliest. There is no other way. Another thing to add, when you are referring the patient, as we said, a golden rule is the sun should not set on a hip fracture. The challenge is most of these patients are on blood thinners.
Yes.
And invariably they would have taken that day's dose. So when practitioners get calls, when they have had hip fractures, apart from checking the neurovascular status, please check on the thinners, talk to the primary cardiologist physician, and they should be stopped at the earliest, at least for a day or two, depending on which thinner they are taking.
Is the challenge so high if it's on ecosprin or clopidogrel to not operate on the same day that they have taken?
More to do with the anesthesia part.
Okay.
No, so to add on these elderly patient, what happens when they fell down and relatives are not there? So what happened, the two things happen. One is the painkiller. Avoid giving them NSAID or Dynapar injection at home. Number two, tell them to hydrate and have electrol pad or something. Because when they come after 24 hours, most of the time they have hyponatremia or hypokalemia. And if they're diabetic, if hypoglycemia happens, and that makes, so this is very common. Coming them after 24 hours, they're coming to, once the relatives are coming or not, and they themselves patient, because in bed, they don't have facility for, they don't want to use bed pan. So they don't drink at all. This is very common in elderly. They are dehydrated, and this require quite hydration. So medical stabilization, even if you get phone call, tell them to have plenty of water, manage their, and second thing is this blood thinners. So ecosprin, we can very well operate with ecosprin. For clopidogrel, I think we have to stop for 72 hours.
Sure. So moving on to the next question, already Dr. Nitish mentioned that shaft of femur fracture, the risk stays of 1.5 liter to 2 liters of blood loss. So how do you stabilize such patients before you actually take them to OT? If you can just brief what is shown.
Whenever the patient comes to emergency deformity in the thigh, that maximum is a femur fracture. In young patient with high velocity of injury, the patient, we have to check ABC first of all. Other injuries we have to rule out.
Correct.
Once we have ruled out other injuries, as they told ki femur fracture always associated with, maximum it is associated with 1 to 1.5 liters of blood loss. The patient may go into hemorrhagic shock. And nowadays, we need immediate catheterization to monitor urine output and give some IV fluid to stabilize the patient. If needed, after CBC, if the hemoglobin is less, then we can blood transfuse the patient. Once the patient is stabilized, they splinters the limb and get the X-rays done. Once the X-ray is done, then we can apply some skeletal traction. If other comorbidities are there, I mean, if we can't take the patient to surgery immediately, then we can stabilize by applying some skeletal traction or with Thomas splint. Then the patient may go into fat embolism also, especially between 24 to 72 hours. That is very important. We have to rule out fat embolism also. And it may be associated with compartment syndrome, but very less likely in femur fractures. And maybe femur fracture associated with some pelvic injuries. So always we have to rule out pelvis also for fractures.
I hope this patient comes to Dr. Siddharth with knee injury after playing football. You know the patient, right? No or no?
So first thing is, important thing is, if there's once you see there's no fracture, it doesn't mean that nothing else is injured. There are a lot of things to injure. So there's always, so if there's a knee injury, there could be swelling. So first thing is to tell them to not to put weight. they can use some stick or a walker. If they keeps on putting weight, then they get further damage. So immobilization or not putting weight, that is the first advice. And then you do X-ray and if required, NSAID and MRI to rule out. Because immediately in acute knee injury, it's very difficult to examine by the classical test for cruciate or meniscus because there's an injury. So yeah, that is important.
The simplest thing to add is a long debate. Whenever we have such situations, we don't know
Put it and
what
then
position to give. A simple long debate.
Sure.
Another thing is if you are putting knee brace for a longer time, I think we should start some kind of a DVT prophylaxis after 2-3 days. I've seen 2-3 patients, just a simple splinting of foot and they got a DVT. So this is recently, for last 3-4 years, it's getting more common after COVID.
So my next question to Dr. Nitish, you have this patient coming. Should you prefer that someone who saw him earlier attempted a reduction, or if he's not confident, there's too much of deformity, there's puckering of skin?
So yes, I believe that each and every physician who is a medical specialist in any branch or field, we should know how to handle emergencies. As an orthopedic surgeon, I should know how to give CPR. So similarly, as a general physician or any other specialist, we should know how to reduce dislocation. So reduce dislocation doesn't always mean that we should reduce it anatomically. But then we have always been taught that what is the anatomical position. We all know that. So anatomical position is whenever we are standing, our legs are straight, our hands are supine, and your ankles are straight. So we all know this anatomical position. So seeing this injury, we know that this is not anatomical. So simple way to make the body anatomical is give it gentle traction in the line of the bone, in the axis of a long bone. So simple, give it gentle traction in the axis of a long bone. So this is a simple rule to each and every joint and each and every bone related to fracture or dislocation, both the things. So if it's elbow dislocation, give a simple gentle traction, splint it, send it to a specialist. If it's an ankle dislocation, give a simple gentle traction. Most of the dislocations, if elbow dislocations, ankle dislocations, they are very well treated with simple gentle tractions. Yes, shoulder dislocation sometimes needs sedation in an ER, but sometimes they are also reducible and they need special maneuvers. But other joints, elbow, wrist, knee and ankle, they are able, you will all be able to reduce with gentle simple traction in the axis of a long bone. Hip dislocations and shoulder dislocations, they need special maneuvers to reduce it into in the ER by a specialist.
In a clinic practice, most common is finger dislocation. So if you reduce the finger dislocation within minutes, it is very simple. And the same patient comes to next day, it is very difficult because there's a lot of swelling and you can't reduce it. That require open reduction. So if a patient coming to you with PIP joint, DIP, immediately you try to reduce it. It is very simple. Thank you.
So the dislocation which is difficult in hand is Kaplan's dislocation. As sir told, majority of the dislocation in hand, they are easily reducible with traction. But first, MCP joint dislocation, that is difficult to reduce. If you are able to reduce it, well and good. If you are not able to reduce it, most of the times we need open reduction for Kaplan's dislocation.
So I think well said by Dr. Nitish, every orthopedician should know CPR. I'll catch hold of you today. So since we have been hearing about Lis Frank, it is bad, needs to be operated. Question for Dr. Samir, what exactly is Lis Frank? How can we have some red flags that this could be before we actually send for imaging?
So Lis Frank, basically injury is labeled after a French surgeon, and that is the Lis Frank ligament, which is connecting the second metatarsal base with the the first metatarsal base. So it's a big chunk of ligament there. And Lis Frank is easily missed because the foot alignment pretty much seems okay in some types. There are few types where it plays open, which is very much obvious. These are one of the few foot injuries which need surgery and not plasters, because if Lis Frank is missed and you put a plaster, The commonest challenge is the arthritis that develops in the midfoot area and the chronic pain it will give. So that's why Lisfrancs are very important. This is the telltale sign, the bruising on the Lisfranc injury. So it's very much obvious.
And last but not the least question for Dr. Sharif. We have been dealing with lower limb, okay. The patient has come to me with fall and now complains of lower limb weakness, but the PBH X-ray is normal. Now what? Have we missed something?
Whenever there is a weakness in lower limbs after fall or injury, you always suspect spinal injury. Okay. Definitely. Weakness may be because of fractures. After after imaging, we rule out the fractures, but there is no fracture in the pelvis area and thigh bone, leg bones. Then we have to always suspicious of spinal injury and don't mobilize the patient without confirmation of spinal injury. So apply some brace, get the imaging, and assess for another clinical signs like any loss of sensation is there in the legs, or any bladder and bowel involvement, is patient able to pass urine and stools, and if patient feels any weakness in the lower limbs, always we can assess the spine, see for the spinal tenderness. If spinal tenderness is there, get the imaging done after the splint test. When the fracture is confirmed, these paralysis or weakness is recoverable if we go for immediate intervention. If there is a spine fracture, patient with weakness, then we will go for CT to assess any spinal cord compression by the retropulsion or fracture fragment, by the fracture fragments. Then we can assess the MRI for the compression, how much it is. Then we can go for urgent decompression by doing fixation and reduce the fracture.
So that ends us with the lower limb injuries. Yes, sir? Pod spine. So I would deal with this maybe one-on-one with you. We limited to lower limb. Spine is something more complicated. We'll address that in the next part. So I think that ends with the polytrauma session that we had. Fantastic elite panel to have. Can I request S.V. Kulkarni sir to felicitate the polytrauma panelist? So we'll start off with Dr. Siddharth Yadav. Yes, sir.
Before felicitation,
I would like to add, before like 21 years back, and Apollo has started this ERs and Nitin in 2016. Before that, there was no concept of emergency in Mumbai and Navi Mumbai. So I remember 15 years back, patient has come to ER in some hospital. They just put an IV line and Dynabar, then ki doctor aane wala. And many times relative used to stand out to the hospital, kidhar hai doctor? Even for a small fracture. So after this ER concept, which is your Nitin and 10 years back, Apollo is the pioneer, and that is now done. In fact, in Bombay also, once we started, things are changed. Now it is very peaceful. Many of the time I don't get call. Most of the things are managed in ER, and we have established pathways, and thank you very much for that, and I really appreciate that.
Thank you. Friends, I'm really happy to see such a full hall. I have to share something. I was practicing in Khopoli from 1983. Many of them you were not born or not in the minds of your parents also. But I have seen maximum number of polytrauma cases. The first day of my practice, a police Havaldar comes to your clinic and says, Sahib, civil hospital la chala, 73 patients. 73 patients in one ST bus just gone down the ghat. Imagine karo. 55 official capacity, rest of people were standing inside. So polytrauma patients are always poly in number. They don't come 1, 2, bike wala 2 rahega, car wala 4, 5 rahega. Second, some simple observations, clinical observations. If the patient is sweating, either he is hypoglycemic, or he is having a MI, or he is bleeding internally. Internal bleeding, telltale sign is sweating without any reason. So forget rest of the things. Third point, somebody who is absolutely listless, lying ekdam loose, There is one word in Khopoli people use, lust. That is a combination of loose and sust. And his clothes are soaked with sweat. Don't even do full blood sugar. That time we had scalp pens. 20 number scalp pen used to be yellow number, yellow color. So, yellow scalp pen and not less than 4 to 5 bottles of 25% dextrose. And the dead man starts talking and walking. So please consider some medical conditions which are associated. One more point which always happens in accident is the first thing to go whenever there is accident is your wallet for the money or whatever. But there is no identity. So there may be people who may be sensitive to some drugs, sulfa, diclofenac, all other things. That whole identity is gone. Some odd things you require. Suppose if there are 50 people lying on the bed, first thing you require is a scissor to cut. अभी खोपोली के सिविल हॉस्पिटल में 4 सीजर में से 2 सीजर तो ऐसा गायब रहता है. So you need something more. You need more buckets to drop off their soiled clothes. And when there is a sort of an epidemic of polytrauma, then you need to catch up every section of the society. It is not the hospital which is important. Unfortunately, I have seen Khopoli from the 71 bus crash to AIH, but there is a recent epidemic. All the religious meetings which are the next, there is something coming in the next few days. The stampede which occurs, that takes lives for no reason. So we have to be very alert. As a medical professional, I really congratulate Akshay and the whole emergency department for organizing such type of CME and very practical, wonderful discussion on all the emergencies. You have to excuse me for leaving early. Thank you very much.
Can I request Siddharth, sir? Dr. Sameer Chaudhary. Dr. Nitish Arora. And Dr. Sharif Dudekula. Group photo. It's working. Can I request DMS sir, Dr. Ravi Shankar sir, to come up to felicitate our patrons? We'll start off with Dr. S.V. Kulkarni sir. Can I request Dr. Ghansham Dulera sir to come up? Can I request Dr. Alka Patnaik ma'am to please come up? Thank you. हाँ चलो Yeah.
Yes. I'm very thankful to Dr. I'm very thankful to Dr. Nitin Jagashia and Dr. Akshay Devdar for arranging such a nice program. Especially any hospital is as good as their emergency department is there. So Apollo is good because of they got a very nice emergency department who take care of all the seriously ill patient, whether it's a neurology case, whether it's a cardiology case, and whether it is a polytrauma cases. So all the cases will ultimately depend upon the emergency department. So emergency plays very important role. So today they started with the animal bites, then there was a cardiology cases, heart cases, and then neurological cases. So we had a very good learning session, and it was a more of an interactive session. So everybody must have learned quite a lot. Thanks a lot for arranging such a nice interactive program. Thank you very much.
So we might be wondering, it is 1 o'clock, like I started. We don't like to run late, so I'll just make this brief. Some of you have already commented on the ambulance by Apollo, and you must be wondering what this is on the side, and we keep putting up CAD. So there's a short video that I'll just like to play, and then we would describe it.
Hello, Apollo Hospitals? Yes, ma'am. There's an emergency at my place. I need an ambulance right now.
No problem, Sunita. Since you are registered with us, we have your updated address.
Okay.
I'm assigning an ambulance to you right away.
Alright.
You will get a message, and in that message you'll have a link. You can click on that link to track your ambulance.
Alright.
If there is any other issue, you can call 1066 right away.
Okay.
Thank you, ma'am.
एम्बुलेंस 5 मिनट में आ रही है.
Okay, Vivesh, what are the vitals at present? Kindly connect the monitors, SS, DCS and record RBS please. Okay, doctor. Thank you, Vivesh. I can appreciate the vitals. Kindly start 6 liters of oxygen via face mask to the patient. Also help me by assessing the patient's pain score and start analgesics adequately, please. And please use the ice pack machine to check his blood work.
So how is the patient's condition?
So when we had provided for the smart ambulance and we evaluated him on reaching there, his condition was very unstable. His oxygen levels were low. We managed to stabilize him by starting some oxygen. During his transit from home to the hospital, we have found out that he's having a heart attack. So right now we are shifting him for angiography to be done.
In today's age, we like to track our food delivery as well as our grocery delivery. Then why not track our emergency medical services? Apollo Hospital brings to you computer-aided dispatch. That means in any medical emergency, you call 1066, the ambulance will get dispatched to your location, and at the same time, you can track it. Apollo never sleeps, so that you can sleep peacefully. In any medical emergency, trust on us.
So the last session, as you saw the ambulance, you might have captured some of it. With today's day and age, we've got mobile numbers, databases. So if you're registered with Apollo and you call, we can actually get the address, dispatch the ambulance. So that has been added. Plus, बाकी सब चीज़ में tracking link जाता है. So all those things have now been added. For the last 3 years, we already had the audio-visual connectivity where we can see inside the ambulance and assess the patient. And like you've been seeing from 9 o'clock, all our specialists are integrated in this system. So जो भी आ रहा है, we have already seen in the ambulance, we have activated that. For example, about a week ago, I went for a pickup to one nursing home in Panvel, and while I was coming, we had activated the neurosurgical team because it was a 9-year-old with a subdural, which we knew at that stage. So when we came here, handed the CD over to the radiology team, they got this CD played and the neurosurgical intervention. So all these are benefits of being with Apollo, which strengthens the emergency response. So my topic given to me is what, how, and why. So I will just take 5, maybe 10 minutes of your time just to consolidate, summarize what we've been doing from morning. So what as in what is ER? So Siddharth has left, but thanks for his kind words that he mentioned about the difference. So what is the difference between casualty and an ER? In interest of time, normally I would ask the questions, but I don't want to keep you from lunch. So casualty सोचते हैं तो ये scene दिमाग में आता है कि कौन चिल्ला रहा है, क्या हो रहा है, chaos basically in simple terms. And you will have somebody running and all these kinds of things are happening. Definitely things are available, people are being looked after. There was nothing wrong with the casualty at that time, what was there. But what is difference in ER? To simplify it for the common team would be, यहाँ पे भी सारे books available है library में, but ER में they are stacked up. So you know कि कौन सी किताब की ज़रूरत कौन से situation में आएगी. That is the difference. Casualty में भी everything was available. ऐसा नहीं कि they were not treating. Same way if you look at clothes shops, all the clothes are available, different sizes, different colors. So we have various gadgets we've spoken about, thrombectomy, Thomas splint, this, that. सब कुछ casualty में भी था. Thrombectomy नहीं था, that is new. But whatever drugs were there. But ER is just an organized way of looking at the whole thing. So that is the answer to what and how we do it in Apollo. You've just seen a glimpse. There is a dedicated number. It is answered by a trained physician. The ambulance which is dispatched has got a trained personnel. And then inside the ambulance, like you saw from next week, we are actually doing a point of care blood test. So we'll be doing a troponin and a blood gas inside the ambulance when there's a transit of 10 minutes, in that 10 minutes we will have that result. Of course, we will not be doing it all the patients. There will be guidelines, there will be a protocol, indicators where it needs to be done. There has been a lot of discussion of neck or femur, which we will not be doing any blood tests in the ambulance. But yes, we'll be putting an IV line and giving the non-NSAID painkiller, if everyone was listening. So moving on to the department, some of you might have seen it. It is organized in that way, like I showed you about the clothes or the books. So everything is linked up. We've actually got a pediatric bed, even in the resuscitation. How does that help us? I will just skip a couple of slides. So there are these protocols that you would have seen when it comes to ACLS, ATLS. There's also a pediatric, if you see this formula over here. So these are things that are actually set up inside the department. That is what an ER is different to the casualty. Why we are doing it? Do I need to go into that? Yes, no? We've all been talking about time is muscle when it came to cardiology. You saw that graph falls off at 4 hours, like Dr. Charan told you. Microbiology way, the muscle is all damaged. So the time starts from when they arrive, right? So the time, ये start time कब शुरू होता है? Just discomfort feel होता है, not when they reach the hospital. So we need to work on that. Same way for neuro, we have gone through that. Time is brain. So that is the reason we have these door to balloon, door to needle, door to this. So aim of today's session is actually before the door, the awareness of Dr. Shekhar mentioned to you, or we asked him the question, stroke ready hospital. So he said stroke ready unit, heart ready unit, trauma ready unit, advanced trauma care. These are all things that have to be there. Why we need it? Because that time critical nature of all of this. Tranexamic acid within an hour, this within 10 minutes. There are so many such things that need to be put together. Now the point is, how do we do it? Everyone sees Formula 1? It should play, not playing. एक्शन तो एक ही मिनट का था, राइट? उसके पहले इतना लंबा चल रहा था, बाद में भी लंबा चल रहा था. So what was that? So that is the difference. Actually setting up what you saw, all the team members in the matter of a few seconds, they have changed all the 4 tires. They have replaced the entire fuel capacity. They've done all those things, but that was only possible because they have practiced that together. All the specialists, whether it is neuro, cardio, ortho, nephro, whatever, along with the ER, along with the other infrastructure. So that is how an ER functions, or that is how it should function, I should say. So resuscitation needs a system. It doesn't need just a few skills that few people can have. And that is the difference when you have a advanced emergency care. Of course, you need defined roles. You need people who have the roles, and most importantly, they have to be competent. But they working together, they training together, so that जब वो गाड़ी आके रुकती है, वो 30 seconds में सब कुछ हो गया और गाड़ी निकल गई. So we have a MI patient, like you see, we have to get them to the cath lab, right? At that time, we cannot start looking for कि razor किधर है, shaving करना है, क्योंकि they are going to poke the femoral, or we have loading dose किधर रखा है. All of that has to be pre-practiced, pre-rehearsed, kept in the right place in an organized fashion. Center of it, obviously, I'm going to say it, is the emergency physician. Okay, for people who are not yet aware, this is a recognized postgraduate qualification. It's been there for over 10, 12 years now. We at Apollo ourselves are DNB accredited. We have 2 students, we are in the 7th year. So 4 batches have passed out. So that is what it is. I don't want to elaborate, but obviously in the emergency situation, just like many of you are alone in your clinics or in your setups, you have to have all various clinical as well as other skills. So we are trained into getting that done. Infrastructure. So obviously you cannot function without having the infrastructure. That is where your neuro or a stroke ready, you need that MRI. Dr. Vishal Chafle told you all, 12 minutes is our diffusion flare in MRI. How did that come up? That came up because the emergency, radiology, neurology, and most important, our administration, DMS sir is right here. We have all sat together and created that. We made sure we are not going to do a half an hour MRI scan when there's somebody who is potential for a stroke and we need to get the medicine inside. Similarly, I'll skip that. We have protocols for major things. What stroke, everyone is aware. So one additional thing I will add to being a ready hospital is actually monitoring this data. So where the accreditation comes in, you've heard of NABI, JCI, but being ready means you're monitoring this data. Every month, we have to submit to sir has to submit to his sir, कि कितने लोगों का 1 घंटे में नहीं हुआ, क्यों नहीं हुआ, क्या reason था, ये क्या था, वो क्या था. So all those things have already been tackled, but they are being reviewed on a monthly basis. They are being checked on what else we can do so that the next time we get that time down. So we are already targeting ourselves at 45 minutes for thrombolysis, not 60 minutes, which is the international standard. Because we've just finished trauma, I put this one example of the protocol. So if somebody ends up in our emergency department where there's a limb which is threatened, we have a 45-minute protocol for that also. We will get the CT angio irrespective of the creatinine, and we'll get that patient to operation theatre, dare I say it, irrespective of the deposit. So management has already signed that off. When there is a MI, when there is a stroke, when there is a polytrauma, when there is a dialysis, when I can go on and on and on. Anything that is life or limb threatening, we have got those processes in place. We've actually kept that ready. So that is what I would talk about, what, why, as we all know, and how we are doing it. To summarize, obviously a well-staffed ED is a need for any multi-speciality hospital, obviously in any hospital really, but the role of the physician changes, just like all of our roles change where we are. So what community we are serving. So today's day was mainly for that, and like we keep saying, there'll be a second day next month, is to create that kind of awareness. There are definitely other setups that can do it. It is not that I'm saying this is the only setup, but actually being aware, because if you get a call from a friend, a relative, or your patient, and you are able to pick up, okay, this is something time critical, getting them to the right place. Like we had 2 days ago, we received a stroke patient that went to a clinic and they sent it, and the door to thrombolysis was 40 minutes. And we've all seen the benefits of that, we've all discussed that. So that is the strength, what we need to strengthen Navi Mumbai. Like again, we started this morning. We are a structured city. Everything has been done in a systematic order, and healthcare also needs that. And we need to come together and create that kind of a system. I have a slide for questions. Sorry, orthopedic surgeons, they're still here. But it is the easiest punching bag for ER. I was going to say another nasty joke, but I'll wait for later. Okay. This is the emergency team here, and this is the most important slide. So one of the questions you asked me in the morning is, how do we get in touch? So on the left is the duty doctor, trained emergency physician that you can contact. You will just scan it and you can save it in your phone. The good part is, even if you don't save it, we are giving you a memento with the QR code. So you can save it from your memento. Even people who haven't presented will be given a memento for that reason. So you've got my number, you've got Akshay's number, but this number is in the ER. You all are all doctors. You all can talk to a doctor directly and say, this is my concern, this is what is going on. And they will make sure that Nitish is ready, Samir is ready, Siddharth is ready, Vishal is ready, or whoever needs to be ready to receive your patient. Thank you. Sir, please.
Yeah. So, Dr. Nitin has summarized it very, very well. The evolution from casualty to the emergency department or emergency room concept, what we have just seen. So casualty typically meant an accident. And also if you see that the military calls any gunshot wound or any mine blast injury or anything a casualty. So it has a connection when it was only meant to be handled by the casualty when a patient comes with accident. Not any emergency. What we are now having is an emergency department. So its evolution took place, then in between it was called accident and emergency, and we are having a proper emergency department which takes care of casualty, which takes care of any emergency. Even patient or relative apprehending something is an emergency. So at any point of time, you come to the ER and you are provided a multidisciplinary team. Though the center of the action is the emergency physician, but having a multidisciplinary team makes it complete emergency department, because we don't want to have a system where you come, then one specialist is available, then we'll say for this you need to go to another hospital, or we don't have it, we have to call somebody from outside. It can be an emergency department only when you have everything under one roof, and this is what Apollo is having. Rather, we are having an emergency medical system, right from home care to picking up the patient, ambulance, to the super specialty treatment. It's all under one roof. And the whole activity, all the activities are monitored from quality perspective. We have our own deadline, we have our own benchmark. We manage exactly what is the door to balloon time. The patient comes at the door of the ER, and balloon time means if patient is having a cardiac arrest, patient is having a myocardial infarction, what is the balloon time when the patient is inside the cath and the patient's arteries have been opened up. So that has been meant. Stroke pathways we are following, and each and every parameter is being monitored, and that's what makes it a complete department. And we are here to convey to the general population, to the people, we want to develop their trust in our Apollo emergency department, that you call 1066 and don't rush and bring the patient in your vehicle. Rather, you call 1066 and leave things to us. We will reach there, we will start management there at the doorstep, en route, in the ambulance, and in the department and in the hospital. So thank you very much, all of you, for sparing your time and coming and spending time with us on a Sunday morning. Thank you.
Can I request Ghanshyam sir to come up, please, to felicitate DMS sir? Also to felicitate Nitin sir. And last but not the least, myself.
Very nice MOC and very nicely Thank you.
So that's it from us. Lunch is ready. A big thank you to all of us. A big thank you to the patrons, DMS sir, Nitin sir. Excellent job by the marketing team to help us out. And we hope to see you in second part of this within a month with pediatric, obstetrics, respiratory and foreign body, ENT and gastro.
Whatever else you will want.
We'll talk to you and then decide. Yeah. Thank you.